Computer. There we go. All right, so we're going to start with the hip in thorax today. Musical chairs COVID edition. I love it. So a little bit, we're going to fly through kind of some of the review, but then we're going to talk about specific thorax of the hip itself. So structure and function of the hip. Obviously, we have the pelvis, the femur. We've already covered this in kinese. We also talked about the neck or the column of the femur having that 130-degree angle, which then will lead down to the Q angle of the knee. But again, all of these, you thought these bony landmarks are going to go away. They don't go away. They come back even when we're doing thorax, because a lot of times when we're doing thorax, we're going to have to be palpating these. So we've got our nice ilium or pelvic girdle, right? Acetabulum, pubis, pubis symphysis, ischium, all of that provides structure for our whole body. And if you look at this, I mean, again, I know I've said this before that I'm amazed at the human body, but if you look at the way this part of the body is designed, it is designed specifically to disperse weight bearing through the legs. So all the weight of your body comes down here onto the ala, right, of the sacrum. And that ala then disperses the weight out through these iliums, which sends the weight down into this acetabulum, which then sends the weight down through your legs. The body is a uniquely designed machine. If you look at, you know, animals that are quadruped or stuff like that, their weight, their actual pelvic girdle is shaped a little differently in order to allow them to shift the weight more horizontally versus vertically like ours is. So it's just amazing that we've kind of developed over the years this way, and that's just the way it is. Oh, too far. So we talked about it being a spheroidal triaxial joint, right? It's a ball and socket triaxial joint. We have the concave acetabulum and convex head. We've talked about all those ligaments, right? We have the iliofemoral ligament. Sometimes that'll be called the ligament of Bigelow. It's no longer called that. We're getting away from naming stuff after people, like fallopian tubes. We do not call them fallopian tubes anymore. We're just kind of getting away from naming parts of people's bodies after people. Just seems weird. So they're named a lot of times after where they start and where they end. So iliofemoral, pubifemoral, ischiofemoral, right? We have our iliofemoral that limits extension. You do need to know this section here for your boards. That's why I put it in here. So the iliofemoral, right, going from the ilium to the front side of the femur, is the one that's going to limit us into extension. We don't have a lot of extension. That's one of the reasons we don't. It also limits us into external rotation. The internal rotation and the adduction side is the ischiofemoral, coming from the ischium down onto the femur. And then the one that limits adduction, I think, is probably the easiest ones to get. So the one that limits us from spreading our legs very wide is the one that comes from the pubis and goes to the femur. That one kind of is self-explanatory. Yeah, it was somebody's last name, Fallopian. Yep. The doctor that kind of found it. Just imagine walking around that with the rest of your life. Hey, there's some tubes named after you somewhere. So this is looking at that roll, spin, and glide, right? So I designed this specifically to help you go through this as well, because this is more of a thorax thing than it is a kinese thing. Inflection, right? Inflection of the hip. Usually the roll is going to be anterior and the slide's going to be posterior. In extension, posterior, anterior. Abduction, lateral and inferior. Adduction, medial and superior. And then we have our internal and external rotations, which are opposite of each other. That's a lot of stuff to memorize. It really is. What I would suggest if I'm studying this and I want to learn it for my boards, I'm not as mean, I don't really specifically. The extension and flexion. That was a really good draw to swear, Keith. That was great. The extension and flexion are the ones they're going to ask you the most of your questions about. And so when we're talking about the roll and slide of the femur, those are the two that I would focus on studying when I get to the boards part, is that, you know, in flexion, the femur is going to roll anteriorly and slide posteriorly. That makes sense. When I flex my hip up, It's starting to roll to the front, but in order to get into the socket, it's going to kind of slide backwards. And then to extension, it's going to roll posteriorly, but it's got to slide slightly anterior to lock into the socket. So most of the pelvis, we've got some distal fixation going on, right? That concave acetabulum when we move on the convex femoral head. The acetabulum will slide the same direction of the pelvis. That makes sense, right? Because the reason I put that in there is one of our students actually had a question that talked about, does the acetabulum move independent of the pelvis? Although that seems like a really silly question, because the acetabulum is part of the pelvis, those are the type of questions you're going to get when you're sitting at your boards and all of a sudden you've got this random question that's asking you, does the acetabulum move independent of the pelvis? And you're like, does it? Did we talk about this? I don't know. And then they're going to get you sitting there for 5 minutes thinking about it. It can't. It's impossible. The acetabulum moves in the same direction as the pelvis. The pelvis are hooked. They don't move differently. If we had an acetabulum that was independent of the pelvis, that would just be really, really, really weird. The hip on balance and postural control. The hip is the last balance strategy before that step, right? We talked about it, the strategies being the ankle strategy, right? We kind of roll our ankle to get balance first. Then we have our knee, right? And we have that drop strategy where we kind of bend our knees and lower our weight. Then we hit up to our hips and we kind of rock on our hips. And the last strategy is kind of that step or the expansion strategy. The hip's kind of our last balance strategy. Hip's also kind of the last area that can absorb shock before that shock goes into your spine. So if you have problems with the hip, specifically with structures and the function of the hip, that means you're more than likely going to have some back problems. Just because the structure and function of the hip is to absorb the impact and shock from the back. So it takes away a little bit of that ground force that we get every day by stepping down and down and down and down and sending those shock waves up. That's why the acetabulum's got that labrum. That's why the acetabulum's labeled with that articular cartilage. It's really to help us, reduce some of that shock wave going up to our spine. And just talk to somebody that actually has had hip damage or has torn something in their hip. If you ask them, most of them are going to say, yeah, I've got back pain too. Well, why is that? Well, they're favoring one side, and now all that, instead of getting weight bearing down through the hip, that weight bearing is going into that aspect of the spine. They're going to get back pain and back injuries. All right. Talking again about the motions of the femur, right? The femur goes up, the femur goes down, the femur rotates out, the femur rotates in. We already know that. Motions of the pelvis. The pelvis has anterior and posterior tilt. And remember, those headlights, the ASIS, are what tells you what the patient's in. If the headlights are pointing towards the feet, they're in anterior tilt. If the headlights are pointing toward the head, they're in posterior tilt. Pelvic shifting is where we kind of do that shift from side to side and standing. And you've all done that when you're standing in line for a long period of time, right? You're waiting at Walgreens for your pharmacy, and you're standing there and, you're on one leg. Up, you shift the weight to the other side. Up, you shift the weight to the other side, and then you stand up straight for a little bit, and then you're back to shifting the weight. And then finally they call you and you're like, it's about time. Why did you make me wait 2 hours for my prescription? And the pharmacist is just looking at you like, really, dude, this is just a job for me. Wait, no one else? That a little specific? So pelvic shifting is just that shift back and forth. We can have lateral pelvic tilt, the impatient stance, exactly. We can have what's called lateral pelvic tilt. So usually the outside wings of the pelvis are level on either side. So if we put our hands around and get our ASISs and get our PSISs, if we look at our hands and have them out, they should be equal at the height if the person's standing up straight. The pelvis can laterally shift. What could cause the pelvis maybe to laterally shift and maybe have the right side higher than the left? What do you think? One leg longer, good. That's one of the common ones. Yep, uneven legs. Shoes, absolutely, believe it or not, right? And any lady that's ever broken a heel can tell you that can really mess things up, right? That can actually shift the pelvis higher or lower. Not that I know anything about wearing heels. I did do that one walk in her shoes marathon. I will never, ever do that again. Try finding heels for a guy to walk in that is 10.5, 4E feet, and it doesn't really work. It's a really cool marathon, but man, I don't understand how you ladies wear heels. What about the spine? What could happen at the spine that could cause the pelvis to shift? Scoliosis, right? So now I've got a curve on my spine going this way, so the pelvis is going to try to correct it by shifting up on one side. So that's lateral pelvic tilt. Pelvic rotation. This is a little weird. The common terms for this are nutation and counter nutation. Again, terms that are going away. So they're just going to be pelvic rotation, anterior and posterior rotation. So instead, tilt is where one side's higher than the other. Rotation is maybe where they're like this. Or this one's straight on and this one's rotated forward or rotated back. It's really common in mommies to get that when they're pregnant. Why do you think it's common for the pelvis to kind of rotate when the baby's in there? Well, baby is taking up what? Yeah, they're getting ready for birth, and baby's just taking up space. Right? They're parasites. They're starting to take up space, and so the pelvis kind of has to shift. And in order to make some space, sometimes it'll rotate on its own. And holding the baby on your hips, another one that can actually cause it. You're exactly right, post-birth. Also, you got to think about it. When the woman's pregnant, what's that hormone that's going through their body that's causing all those ligaments to kind of get loosey-goosey? Relaxin, good, right? So now you combine, inpatient mommy stance, because, any leg that you stand on when you're pregnant, from what I understand, hurts. Along with having this extra, 20 to 30 pounds of weight on the anterior surface of your body and having to shift back so that you can get it over your center of gravity, right? And a kicking baby that's in there just pounding on your sciatic nerve and your pudendal nerve and your bladder. Well, it's no wonder why the pelvic rotation happens. It can also happen in gymnasts, right? Especially ones that do like floor activities, all the flipping and twisting and turning and all that fun stuff. It's really common for them to get a slight pelvic rotation and start complaining about pain in the pelvis. And what it is just all those ligaments are now stretched really weird. The good news is a PT can do a technique called a pelvic shotgun. That sounds like something I want to have done to me, right? Pelvic shotgun. But what that helps do is realign those hips. Now, that is a grade 5 MOB, so it's not something we should ever be doing. But you'll be amazed at people that have back problems that when we get on their pelvis, the problem's not with their back. The problem's with their pelvis and their legs. I had a patient, like several patients, but I can remember specifically this guy that we saw back in Pennsylvania who had just excruciating low back pain. He was a businessman. Everything we did for his low back pain didn't work. It didn't work. It didn't work. It didn't work. And so one day I'm just like, you know what, let's try looking at his pelvis. And when we looked at his pelvis, his right pelvic side was shifted forward almost like 3.5 inches. Well, if I got my pelvis like this, is it any wonder that it's going to hurt my back, right? Because now all these ligaments are stretched out. All these are shortened up here. Over here, anything crossing across is now screwed up. And so, we started working, normalizing the pelvis back into place. And amazingly enough, the other thing he had urinary problems. Well, again, duh, right? We were thinking that he had some sort of problem with the actual lumbar plexus or something like that. But in reality, it was lumbar plexus just lumbar plexus just getting stretched. And so by kind of realigning his pelvis, and we didn't get back to perfect, but man, we got it back a good bit. Suddenly, guess what? Guess what happened to his pain? It suddenly just started gradually getting better because he started walking better. He started avoiding kind of the positions that got him that. It was a guy that sat like this a lot in his office chair at work, right? He's like, show me how you sit at work. Well, I normally sit like this for most of the day. You're shifting all that weight over onto that one side, and of course you're going to get sore on that side. There is a lumbo-pelvic rhythm when we're walking, right? We talked about that superior anterior shift of 2 inches and lateral shift of 2 inches when we're walking. Well, that's normal for that pelvis to kind of move and flow as we're walking. If it didn't, we'd have other problems, right? We need that little bit of motion in our pelvis to go. We also need our little bit of our motion in our pelvis to procreate. Because if we don't have a little bit of motion in pelvis, it can be painful, right? So we have to have a little bit of motion to procreate. Otherwise, my other way of saying is having sex, right? We need a little bit of pelvic motion in order to do that, is what I'm saying, or so I hear. So number one problem in the hip is flexibility. Again, if we check most of us in this group, almost all of us are going to have some muscle around the hip that is tight. Mostly it's usually the hamstrings and the quads. I know, like I said, I know that my hamstrings are actually usually okay. It's my calves that are bad, but man, my quads are just solidly tight. And again, that's going to cause you to go into specific tilts. That's going to cause problems elsewhere. If your legs are really super tight, oftentimes that's going to transmit that ground force up to the spine. You're going to have back pain, right? So if you have back pain now and you haven't found a solution for it, try starting to stretch your legs on a daily basis and see if that helps. We talked about PF problems, right? Patellofemoral problems occurs more in females because of the valgus movement of the knee. And what is that angle called at the knee again that women have greater than men? It's a famous Star Trek villain, right? The Q angle, good. That's the way I always remembered it. It's a famous Star Trek villain of the knee, the Q angle. No Star Trekkies? Dr. O'Brien's going to be sad. If you have an anterior cruciate ligament strain, where that anterior tibia has been sheared or forced forward, let's think about it. So I've got my normal femur and my normal tibia sitting on top of each other. Now I've got it kind of sitting like this. That pelvis is going to rock kind of like this as well. So even something as tearing the ACL can cause problems with the pelvis. And then Piriformis Syndrome. Does anyone have that in here? It's probably the most uncomfortable pain in the butt you can have. Oh, that was good. That was just great. Piriformis Syndrome is where that piriformis just gets super duper tight. And usually it's either from overuse or lack of use. If somebody sits in the chair, they can get just as much Piriformis Syndrome as somebody that's over-exercising or not stretching enough. But as that piriformis gets tighter and tighter, because we've got that nice sciatic nerve coming down behind it, it's going to push down and push down and push down on that sciatic nerve until that sciatic nerve can't slide and glide in its sheath anymore. Tensor fascia latae or gluteus maximus and gluteus medius problems, right? There's problems where that TFL gets shortened, and that can cause problems. That's going to cause the hip to slightly shift. You can have dominance of the TFL over the glute med. This is a really weird case. I've only seen like 1 or 2 cases of it, where that baby TFL takes over for the glute med, and you get almost a weird kind of rotational motion when you go out into abduction. And so we've got to get that glute med kind of firing. That can also happen if they have paralysis of the glute med. Most patients, and it says dominance of the 2-joint hip flexor muscle over the iliopsoas. Most of us are dominant in rectus femoris over iliopsoas. And you'll find this really easy when you guys get to the hospital and you see patients that have had total knee replacements, and you ask them to do a straight leg raise. And they'll try to start lifting up, and they can't do it. When they can't do it, you know they are dominant rectus femoris over iliopsoas, because at that point, the rectus femoris has been kind of cut into when they did that total knee replacement. And so that's sore, and then they can't get the mechanical force needed to lift the leg. There's one specific doctor in town here that I know that really, for some reason, I don't know what it is about that but that irritates the ever-loving crap out of him. And so he will literally, if the people are in therapy and he sees them and they're not able to do straight leg raises, he'll come up, pick their leg up to like 45 degrees and say, you better not let this hit the mat or it's going to hurt, and he'll drop the leg. So then they have to reactivate that iliopsoas in order to control it. I would say I wouldn't do that to patients. That can get you in some serious trouble. But he's the doc, and who am I to question his malpractice insurance? Dominance of the hamstring muscles of the glute max can happen again. Your glute max should be your primary hip extensor, but those hamstrings can dominate over it. And then use of lateral trunk rotator muscles for hip abductors, right? So those lateral trunk muscle. What's our main lateral hip side body? The bad boy, right? Exactly. What is our main side bender up in the upper trunk? What's the one that allows us to do stuff like this again? Transverse helps a little bit. What's the one that really allows for side bending? That would be a four-sided muscle. Four-sided muscle. Quadratus lumborum, there. That's our main one, right? But we've talked about, so quadratus lumborum here to here, right? That allows us to do this. Well, we've talked about reversal of muscle action again, where you can actually use quadratus lumborum to abduct the hip. Ah, right? Quadratus, right? That's four-sided, yes, right? And lumborum in the lumbar region. But patients can actually start using that, and we may use that to our advantage if patients got some sort of, paralyzed hip or something like that, where we use quadratus lumborum to help with abduction. But over time, as patients have these problems, a lot of times they will substitute their trunk and their core muscles for their leg muscles. And when that happens, of course, pain's going to occur. All right, asymmetrical leg length, unilateral short leg. So we're going to talk about, at this point, measuring for short leg, right? So let me get my little drawers up here. All right, so we have our belly button. Can I do a circle? Do we have a circle? Oh, I do have a circle. Clear that. All right. So we have our belly button. We have our ASIS, other ASIS. And then we have our lateral mal and our lateral mal. All right. So when we are checking to see if a patient has a shortened leg, there are two different measurements we're going to take. We're going to measure for true leg length and apparent leg length. What do you think the difference between those two are? What do you think the difference between a true leg length and an apparent leg length is? When we talk about discrepancy in length of the leg. Well, true leg length is going to be a problem with the bones themselves. Yes, right? True is going to be bone length itself. Apparent can come from any number of other problems that exist. Could be scoliosis, could be a shifted pelvis, could be muscle imbalance. So when we are measuring for leg length, the true leg length is going to go from the ASIS down to the medial mal. So let me put titles in here. So here's ASIS. Here is umbilicus. What's the umbilicus? Another fancy word for? Yeah, belly button. Good. So then we got our medial mals down here. So true leg length, we are going to go from our ASIS down to our medial malleolus. That's going to tell us if the actual leg length is the problem, if it's the actual bones of the femur and the tibia that are the problem. Apparent leg length, we're going to go from the umbilicus down to that medial mal. And right on the medial malleolus, and you can find this on yourself right now if you bring your foot up and kind of feel it, if you go superior to inferiorly on the medial malleolus, you'll come and you'll find this thing called the malleolar ridge. It's kind of like you're going up the hill in the malleolus, and then it kind of drops off. Right before that drop off is the malleolar ridge. That is where you want to measure to when you're measuring either of these. Is right to that malleolar ridge. It's almost right in the middle of the medial malleolus. So you start going down, and there's the drop off. And there's the drop off. So that's where you're going to measure to. If we have a discrepancy, you know, in these, let me clear that one. I want a different color. If we have a discrepancy in this one here, we have a problem in actual bone length. If we measure apparent and we have a problem, then it could be still bone length if we haven't measured true. But more than likely, it's something to do with pelvic shift. And we have to look at that. So when I'm doing these measurements, for the most part, I measure true leg length first. So I'm going to measure true leg length and find out if those are even. If they're not even, then I'm going to go up here and I'm still going to measure apparent because I want to see if they have naturally shifted out. So if I have a leg length discrepancy like I do, I have about a 3 centimeter leg length discrepancy on my left side. When I have that, if you actually come up to my apparent leg length, it's even. So it's weird. You know, this one, I've got a -2 over here on my left side. So if you measure true leg length on me, I've got a -2 centimeter length on the left side versus right, or 3 centimeter, actually, whatever. But if you come up here to my umbilicus, everything's even. My apparent leg length is normal. Why do you think that is? Why do you think yeah, it's at the hip, right? My hip has kind of adjusted at that point to my leg length discrepancy. I've got a pelvic shift now because of my obliquity of my legs. And so now my apparent just looking at me, I look like I have normal length legs. But if you actually measure, I don't. Now think about that. If I'm constantly, so if my left pelvis has shifted kind of like this to allow so that I get those extra 3 centimeters, that means all those muscles that are associated with that have been lengthened a little bit. These have been shortened a slight bit, and everything crossing over is going to be weird, which is going to cause usually low back pain. So how do we do this technique? Well, first thing you're going to have to do is have the patient lie down on their back. And once they're lying down on their back, you're going to let their body kind of settle. So you want them to just sit there for a few seconds just so that kind of everything settles in. You're then going to have them bridge 3 to 5 times. So you're going to have them pick their bottom up off the mat 3 to 5 times. And then relax their legs out. And then you're going to shake their legs just a little bit. Now, when I say shaking, I'm not talking you grab their legs and you beat their legs on the mat. You're just going to kind of shake them out a little bit, even out the pelvis, because you want everything to kind of settle in the way they would normally be walking. Yes, not linguini legs. And I'll see this every time when somebody does that. They'll see them, they're like, grab hold of their legs, and they're just like playing the drums with their heels. No, that's not what you want to do. You want to just kind of pick them up and shake them out a little bit and then let them rest. The first thing I do before I measure anything is I'm going to come in here and I'm going to take a look to see if visually the malleolus are lining up. If they're not lined up, I'm pretty good. I've got a pretty good idea. I've got a leg length discrepancy somewhere. Then I'm going to come along and I'm going to measure my true leg length on both legs. And then I'm going to compare it. Anything over 2 centimeters is an abnormality. So anything over about an inch is an abnormality. If you measure it and you get, 60.5 centimeters over here and 60.4 centimeters over here, that's not going to cause any problem, and that's within reasonable acceptance of error. That you could thought that you were on the ridge and you weren't really on the ridge. But if you come over here and they're 54 centimeters over here and over here they're 50, that's definitely indicative of them having a leg length discrepancy. Once they get their true leg length, then I'm going to come up here to their belly button, and I'm going to come down and measure this. Now, how do I find the patient's belly button? How am I going to know where their belly button and their ASIS is? There's 2 different ways, right? Yeah. For the belly button, I usually tell them, can you point out your belly button to me? Because usually that's one that people are weird about, you palpating. I'm digging for your belly button. No, don't do that. That's just weird. Right? Have them point their belly button, and you've got it, and you can go off of it. Right? For the ASISs, again, big hands, palpate for those ASISs, find them, and you're going to measure off of it. Going into the ASISs like this, where you're digging around, not comfortable. Big hands for that. I will say that some clinicians that are out there will expect you, if you're measuring these, to expose both the ASIS and the belly button. And their theory is to learn it, you have to see it. You have to see their belly button. You have to see their ASIS. I don't like doing that because that bunches up the clothing and can throw off my measurement. So I tend not to have them kind of hike their shorts down so I can find their ASIS on skin. But I will say the best and only way you will truly ever find your bony landmarks is by feeling skin on skin. Constantly palpating over clothes, you're not going to find it. You have to get in and go, oh, that's what the acromion feels like. Oh, that's what the coracoid feels like. Does this overall idea of how to measure true and apparent leg length make sense? All right. Good. We'll come back to it in a little bit because there's going to be some questions on it. All right. We talked about coxa-valga, the larger inclination of the neck of the femoral head, right? And coxa-vara. If I have coxa-valga, what am I likely to have at the knee? So I have coxa-valga at the hip. I'm probably going to have what at the knee? Yes, genuvarum. Good, right? Or genuvera. I don't know which is plural and which is singular at this point. My brain's not wrapping around Latin this morning. I think coxa-vara is single. Coxa-varum is plural, if I remember correctly. I can't remember. But yes, so if I have valga at the hip, I'm likely to have vera at the knee. If I have vera at the hip, I'm likely to have valga at the knee. And usually, again, I said this before, is that the heel or the ankle follows suit with the knee, but it may or may not happen. Then we have our anteversion versus retroversion, right? Anteversions are toe in. Retroversions are toe out. And the way I always remembered that one when I was thinking about this was retroversion has an O in it, so that means that the toes are out. That was my way of helping remember it. I don't know if that helped you at all, but that was my way of helping remember it. So it's all talking about the way that the foot is turned, right? So if I have anteversion, my legs are going to be rotated immediately, and my toes are going to be pointed in. If I have retroversion, I'm kind of out. One's kind of penguin-footed, and the other is, I don't know what would be anteverted. I don't know. I don't know what animal walks anteverted. So we talked about gait pretty heavily with kine. So we talked about the gait patterns and the abnormal gait cycles and stuff like that. And we talked about this antalgic gait idea, right? Don't document antalgic gait. It means painful gait. If I beat anything into you this semester, patient presents with antalgic gait today. Well, fantastic. We all do. We've all got a little bit of pain in our hips and we got a little bit of pain in our legs, and we don't always walk the best. So don't say antalgic gait. Document what's causing that antalgic gait. The patient is avoiding stance phase on the right leg. The patient is avoiding, swing phase on the left side. Whatever it is you see, document that. Don't just document antalgic gait. So major nerves that are subject to entrapment or injury. We have our sciatic, right? So our sciatic is typically going to be problems with the piriformis, but can also still be problems up here in our hip or our back. So the sciatic nerve is going to cause pain down the posterior aspect of the leg. We can also get our obturator nerve, and especially during labor, that obturator nerve can become impinged. Obturator nerve impingement looks a lot like just general low back pain. So it's not like there's a specific referral pattern. If anything, it refers out into the lateral hip. But for the most part, a patient that presents with obturator nerve injury, the problem is that it's pinched back there and they're going to look like they've got a really, really painful low back. And then femoral nerve often gets pinched in the femoral triangle, which we're going to talk about. But anytime you have a femoral nerve problem, that pain is going to refer down the anterior surface of the leg. So this concept of centralization versus peripheralization. Have you talked about this in the PTA110 where you did modalities? Centralization versus peripheralization. Do you guys remember this a little bit or no? Okay, that helps me. It's foggy? Good. All right, so let's draw a line. So here's my spine. Here are my legs. And this can work just at the upper body as well. So say I get an injury up here at like let's go L2. I've got an injury there. I was playing basketball and I went up for a jump shot. And when I went up for a jump shot, I just kind of tweaked my back a little bit. You're going to start with pain right at the area of injury. So you're going to have pain in here. Right? Owie, I've got pain. Most of the time, what do? We pop some Tylenol and kind of go on with our day. Well, if it's a severe injury, the body's going to keep reminding us of that injury. So we're going to have kind of a nagging pain for a couple of days. After a while, our brain shuts that pain off. So our brain comes in and says, you know what? This pain's not real anymore. So it kind of shuts that pain off. And then what happens is suddenly they start complaining about pain down here. I've got pain in my butt. That is peripheralization. That is when the pain really, for the most part, or for reality, is up here in the low back. That's where the pain is. But because we've ignored that so much, the pain is peripheralizing down the leg. If we ignore that pain in the butt, what do you think is going to happen to the pain? So say we ignore that pain in the butt for a couple weeks. Good. Now we've got pain back here behind the knee. Now we've got pain down here in the heel. And then eventually we have it down here in the big toe. That is peripheralization of pain. Now this can happen when you're treating a patient. If you're stretching a patient and their pain started here in their butt and is now out here in the toe, that is no bueno. Right? You can't do that. That tells you that you've got a problem with the nerve and you're making it worse. You want centralization. You want to see the patient and for them to say, you know, my pain started down here, but now my pain is here. And you'll go, that's awesome. And the patient will be like, no, it's not. Actually, it is, right? And especially if you start doing traction with these patients, suddenly that pain in the foot's gone. Then the pain in the back of the calf is gone. Then the knee is gone. Then the back of the leg. Then the buttocks is gone. And then the leg is gone. I meant to do that. The leg should never vanish. I guess that's one way to relieve pain. And suddenly they're complaining that, oh my God, you know what? My leg pain feels so much better, but my back hurts. And that's when everyone should jump up and do what? Yay! Because now the pain is back where it started. And now we can treat it. Until we get that pain to centralize, we're not going to fully treat it. And the patients get really frustrated with this, because they want their pain to completely go away. We don't want it to go away. We want it to move where it's supposed to be. We want it up here at L2. And a lot of times, as it moves back to where it's going to get worse. If we have a typical low back pain patient that we're seeing in therapy for traction and that, it is going to take 6 to 10 weeks, weeks, to get up here to centralization. And this is why a lot of patients come to therapy and they're there for 2 weeks and they leave. Because we don't set an expectation with them, right? We don't say, hey, look, I understand you want your back pain to get better. It will gradually get better. But first, I've got to make it worse. Yeah, it's too much for them to handle, right? They just don't understand that, oh my God, my foot feels so much better, right? My foot pain was this, right? And now my foot pain's up, or my pain is up here in the knee and it's like that. That's a little much for them. They just don't understand it. And that's where you normalize it for them. You tell them, okay, good, we're getting there. And then this will kind of get smaller, right? This will start, the next week you see them. Now their pain is like maybe this in the knee. And then it goes up here and it gets a big pain in the butt. And then that gets smaller. And then as it moves up, until we get up here to the back, and now the back is like that. Good, now we can start relieving the back pain. That's the important part of centralization versus peripheralization. If at any time during your treatment you have peripheralization of symptoms, you've got to stop treatment and let the PT know. This includes adding TENS or IFC to somebody that's maybe low back pain or hip pain. If you put that TENS unit or that IFC unit on the patient, and all of a sudden they're like, hold on a second, let me answer that in a second, Eric, before I lose my train of thought. If all of a sudden you put that TENS unit on the patient's back and they're like, my back feels better, but now my foot hurts. That should be a red flag. That's a red flag that we stop stim first of all and say, hey, I want to get the PT to check this out real quick. You go grab your PT and say, hey, I'm having peripheralization of symptoms with the TENS. That shouldn't normally happen. Is that something PT can decide at eval? As far as what, maybe, Eric, I'm not sure what you're asking there.
Like, can they figure it out if it's central or peripheral?
Yeah, they're going to figure that out based on their testing they're going to do, whether it's, the pain is actually in the knee or the pain is in the back. Definitely. That's why they're going to do multitude. That's why those evals are so long.
So at eval, most likely, and then sometimes it can happen during treatment, like you said.
Yep, absolutely. And it'll happen quite frequently, believe it or not. Then you'll just sit there and they'll be like, hey, is it normal for me to have, pain back behind my knee? And you're like, yeah. Hold on a second, I'll be right back. Right? It's never a good sign to do that. That patient knows at that point they're going to get the PT. So that's when you go, oh, let me go grab a goniometer real quick. And they go out. I don't ever tell the patient, well, hold on one second. I don't know if that's normal. Then all of a sudden the patient's sitting there going, oh God, what's wrong with me? Am I dying? I'm dying. I know I'm dying. Right? So make sure you have a good reason for stepping out of the room before you do. So this is kind of looking at that femoral triangle. So this is the anterior compartment of your leg. And we talked a little bit about the carpal tunnel. But when you look at this femoral triangle here, there's a lot going on in that femoral triangle, right? So here's our inguinal ligament, right? Here's our sartorius. Here's our adductor longus. In that triangle there, we've got the femoral nerve coming down, right? The femoral artery and the femoral vein. All of that's passing through that little triangle. And if you look at the size of this femoral artery. This is why it's really easy to palpate that femoral pulse, right? The downside to it is to palpate it's a little weird because if you look, it's in the inguinal region. So to palpate it, you've got to come in. What I like to do to palpate is I'll find my ASIS. I know where my pubis symphysis is. I don't have to palpate that. And I'm going to come about halfway down between the ASIS and the pubis symphysis. And now in seated, it's a lot harder to palpate it because you've got a lot of kind of soft tissue approximation. But in supine, you can usually find it if you bend their knee up and slightly externally rotate the leg. When you find it, it is a pounding pulse. It's not like the pulses up here where we feel it, you know, but is that pulse or is that them breathing? No, it pounds when you find the femoral pulse. And the reason for that is the size of that artery, right? That's also where they go in if you have a heart problem, right? And they're going to go and do heart catheterization. They cut right into that femoral artery because that femoral artery is nice and thick, and they can send that catheter right up that femoral artery and go all the way up to what? The heart. The downside to that is, and I've had heart catheterization before, after they do that, now I've cut into the largest artery in the human body. Think about that for a second. That artery's got a very, very strong pulse. What else is that artery going to do? It's going to bleed. Yeah, you can bleed out within minutes. Exactly. Yep, right? So they do tourniquet a little bit off when they're doing the heart catheterization, so you don't bleed out in minutes, right? But after you've had the heart catheterization surgery, they've got to come in and they've got to put a tourniquet on your leg. So they're going to come in and let me get a different color here. They're going to put this big tourniquet around. Oh, that's not. Move that over some. Oh, here. Put this big tourniquet the whole way around your leg to kind of squeeze off and allow the artery to close. Sometimes they'll do what's called a star closure, and a star closure is a little piece they put over it. But if you have really, really big legs, guess what? They oftentimes don't have a tourniquet big enough for that, which was my case. They didn't have a tourniquet big enough to fit around my thigh. So how do you think they solve it? How do you solve a bleed? What if you're bleeding out of the neck? What's the first thing you should do? Pressure on it. Yep, apply pressure. And that tourniquet has to remain on for an hour and a half in order for the closure to actually close. Well, they didn't have a tourniquet, so I had to have a nurse stand there for an hour and a half applying pressure to my femoral artery. That wasn't awkward at all. Nope, not at all. Right? You run out of things to talk to after about 20 minutes. But if they don't, you literally can bleed out of there, right? Oh, yeah. Yeah, they put you in twilight. That was the best part about it. They put you in that little, you're not quite asleep, but you're not quite awake. And when they cut into that femoral artery, they had this shield that goes up and across your, like, right across the body. And when they cut into that femoral artery, it's like the worst horror movie ever. It sprays that whole shield. I think I passed out a little bit at that point. But I watched the whole surgery, actually. The video monitor, I could watch the whole thing. It was actually pretty cool. But, yeah, like, if you ever trained in bladed martial arts, that's one of the areas you're trained to attack. In the military, if you have to get into a knife fight, that's one of the areas you're trained to attack. Because you cut that femoral artery, you pretty much ended the fight. And then we look, here's our sciatic, right? We talked briefly about the sciatic. So here we have the sciatic that's normally functioning where it's passing under the piriformis. Here we have the split sciatic, where it passes over and under. Here we have one that passes through and under. And then here we have the one where the sciatic just passes through the piriformis. All these are possibilities for your sciatic nerve, because the sciatic has those two little branches of it. And if you ever get to dissect, if you ever get to human cadaver dissection ever, it's amazing how big this sciatic nerve is. When you separate it out, it feels more like a blood vessel than it does like the nerve. Because normally the nerves are really fine, and honestly, you put a little bit of torsion on the nerve when you're kind of dissecting, and you snap the nerve right off. Not this one. This one's like corded. And it makes sense because that's providing most of the function of our leg. But let's think about it. So here with this number 1, that piriformis gets tight. Now you're cramping down on that piriformis. You got soreness. Here, the good news is if your piriformis gets too tight, a lot of times it'll take the other branch and you'll be radically okay. The problem is now that's exposed. So anytime you bump the hip, well, you bump the sciatic nerve. Down here, we have a little bit different of a problem because now if this is tight, we get the double whammy. We get the whammy of it being compressed and the whammy of it being squeezed. And by far, like the patient that has this here, I've only seen like one that we've had a clear diagnosis of this. And that's only because they did a total hip replacement. And they actually went in and saw that their piriformis and their sciatic was this way. But this one right here, think about it. If my piriformis gets tight, not only is it going to compress the underside of that nerve, but it's going to yank on that nerve. And that's going to create really nasty sciatica for patients. There's no way to know which one of these you have. We can't do an MRI and check it out. The only way we can do it is by opening it up. And I don't think you really want your leg opened up just to know what type of sciatic nerve you have. So let's talk about some pathologies of the hip. So osteoarthritis is pretty much our number 1 pathology of the hip. Almost all of us will have some osteoarthritis of the hip at some point. Our bones are just going to get weaker there. It gets worse with immobility. Like right now, with all of us not doing as much, we are setting ourselves up for osteoarthritis. We are setting ourselves up for osteopenia, where the bones are kind of weakening. And we're also setting ourselves up for osteoporosis. So we've got to get moving, right? Now, it doesn't mean we have to get back to work, but it just means we have to move a little bit more. Common structural and functional impairments. We've talked about most of them with the femoral angle changes, coxa valga versus coxa vera, right? But it can be simple as having bone spurs, right? If you get a bone spur in that hip, it's going to be uncomfortable. When we are seeing a patient that has had either some sort of pathology or something like that, we're going to look at what their limitations, participation restrictions are. At first, in those early stages of recovery, we want to limit what they do with that hip, but we want them to maximize weight bearing. So let's say we've got a soccer player that injured their hip on the field. We want to limit them in doing stuff that is related to their field of play. So a limit avoiding, playing a lot of soccer and stuff like that. But we still want them to walk a lot because, again, the more we weight bear through our hips, the stronger our hips become, because our bones are designed to gain mass based upon the weight we put through them, right? There was a study I was looking at once, and I don't know how peer-reviewed the study was, but I was reading about people that do a lot of push-ups typically have thicker humeruses. And that kind of makes sense, doesn't it? If you spend a lot of time doing push-ups, you're putting a lot of weight bearing through those arms, which means you have a little bit thicker. They're going to develop a little thicker than a normal person that doesn't do a ton of push-ups. When I read that made so much more sense to my hip then, because I thought about it. I'm like, oh, well, yeah, if I walk more and I'm upright more, my hip's going to get more of those minerals and get to become more solid. But overall, right, progressive degeneration is going to occur at our hip. Right, so here's our hips, our femur head. Here's a femoral neck. There's our femoral shaft. And then we have our nice acetabulum here. That was really poorly drawn. That's okay. It gets the point across. If I get a structural defect right here in my hip, like say I've got a bone chip, so that bone piece is gone, but for whatever reason, it's not in the hip, you know, you rotated and it fell out and it got reabsorbed by the body. But now I've got a structural deformity on that head of the hip, meaning that there's not nice articular cartilage there. Every time that hip is downwardly rotated or upwardly rotated in that socket, that piece is going to catch pieces of these cartilage. And it's going to slowly rip at them. As that cartilage gets ripped, that hip is going to progressively degenerate to the point where you will eventually, right? To the point that eventually you'll probably need a hip replacement because of this little notch in the hip. Now, they do have some procedures where they can go in and deburr the hip. But again, they've got to dislocate your hip to do that, so I don't know that I want that done. So when a patient's in that protection phase, right, we've talked about this before. In the protection phase, range of motion should primarily be limited to passive range of motion and weight bearing. Ideally, we want to decrease their pain at rest and decrease their pain during weight bearing activities. That means patients first out of surgery, when we go see them for their total hip replacement, we're going to say, what's your pain level at? Right? We get their pain level, get the prescription. But as soon as we get them up, we also have to check their pain levels again. We have to make sure that the pain doesn't drastically increase with weight bearing. If it does, we may want to document that and see what we can do to relieve it. Decrease the effects of stiffness and maintain available motion. So we're going to do a lot of passive and a lot of active assist ranges of motion where we're getting that hip just kind of, again, motion is lotion, getting that hip moving around. The controlled motion return to function phase, we're going to progressively increase that joint play and the soft tissue mobility. So we're getting more and more into externally and internally rotating the hip. Improve that joint tracking. We want that joint to be able to move nice and smoothly without hitching. We're going to work on muscle performance, meaning we have to work all of the muscles around the hip. So we have to do some external rotation. We have to do some internal rotation. We have to do some abduction and adduction, some flexion and extension. We've got to balance all of it. And we have to start working on aerobic capacity. The key thing here with the hip is we need to be doing some sort of endurance training, whether it's walking on a treadmill, riding on a bike, anything like that. They have to get some endurance training going because that hip is designed to work long periods of time, right? You're designed to be able to walk for longer periods of time. If you don't get some sort of aerobic capacity going, they're only going to be able to walk for a real short period of time, then have to take a break, and then walk for a short period of time, take a break, and that's not functional. But again, we keep this patient education going the whole time, making sure they understand it, make sure they understand what their home exercise program is and what they need to do. Total hip arthroplasty. We've talked briefly about this. What do you think are some indications? Why would we have to do total hip arthroplasty? We have no choice. We've got to do it. Why would we have to do a total hip replacement? That's a definite, we've got to do it. We have no choice. If we don't do it, we've got bigger problems. Right, severe pain, right? And if they're just complaining, oh, it's kind of achy when I walk, we really shouldn't be doing hip replacement on that patient. Although surgeons will, you know, if they're talking about a little bit of pain when we walk, maybe they need to see therapy and see if it's a muscular problem, right? But yeah, if they're in the pain where every time they stand up, it's excruciating and they're stopping to stand up, yeah, then we need to do a surgery. Right? What about a fracture? We break the femoral neck. Probably need to do hip replacement, right? Severe degeneration of the hip, another reason. Articular cartilage worn down, another reason we have to do it. Preoperative management. So patients should be seeing physical therapy before they go in for hip surgery. Why do I say that? Well, the more we can see them beforehand, the more we can set them up for success. We can tell them, day 1, this is what it's going to feel like. Day 2, this is what it's going to feel like. Day 3, this is where you're going to go. And we're going to send you home. We're going to send you this. All that information is really important to give that patient up front so they can make an informed decision. Also, if we can strengthen the hip, there's a lot of studies that have shown if we can strengthen that hip before they go in for surgery, we have better outcomes on the other side. That also includes nutrition, right? They should be seeing a nutritionist or a dietitian to talk about what type of diet they should be eating before they go in for surgery. It's going to be a diet high in calcium, high in vitamin D, so that the bone gets laid down nice for them. Prosthetic design materials. We talked a little bit about this with the with Kines, right? They used to make most of the prosthetic materials out of ceramics, and they did that because it was cheap and it glided really well. But now we're going more with titanium. Titanium is the primary metal we use. Reason being is titanium doesn't chip or crack as hard as stainless steel or something like that. The downside is when those titanium pieces flake, you do tend to get metallosis. And metallosis is an infection of the blood because metal has gotten into your blood, right? You can get that from eating paint chips too, right? Especially lead paint chips from like when I was a kid. And we saw that with the video. Sometimes they do cemented and sometimes they do cementless. It's going to depend upon whether that bone has functional marrow, right? Lead. If they get in there and the patient's got really rich, nice, gooey marrow, like that one that we saw where that marrow just came oozing out, a lot of times they don't have to do a cemented fixation because they're going to pound that prosthetic down in to that femur, and it's literally going to mate up pretty solidly. Yeah, we did watch Total Hip. Yep. That's the one where the goo came flying out when they started pounding the piece down in. Right? But if they open up that bone and that marrow is kind of dry and old, they are going to need cement because they need something to hold that in place. And again, most of it's thermoactivated, which means the more they get up and move after surgery, the more and more solid that hip's going to become. There are some times where a patient will go on non-weight-bearing status after a hip. Excuse me. The reason might be A, they did a non-cement or cementless fixation, and they just want to give that bone time to heal. They may be non-weight-bearing for 2 to 4 weeks because of that. They may be non-weight-bearing because they weren't able to get the hip totally into the socket right away, and so they're waiting till they can kind of pop it once they're out. There are all kinds of reasons why they will say they're non-weight-bearing. If a patient comes out non-weight-bearing, we have to adhere to it. That includes standing up, right? If they're non-weight-bearing on that leg has to straighten out, and they cannot bear any weight at all in that leg. We talked briefly about these surgical approaches, right? We have posterior or posterior lateral. No hip flexion past 90, no internal rotation, no adduction. Anterior, we talked about no hip extension past neutral, no ER, or no abduction. A lot of times they'll also add hip flexion depending upon what they want there, just so that you don't pinch off that surgical site on the anterior side. But anterior lateral is kind of our one we kind of want, but a lot of times doctors don't do this. Most of the doctors that are out there now are starting to fade out. Most of the older doctors that did posterior hips, they're kind of wearing out at this point. They're getting a little older, retiring. So we're getting away from doing just posterior hips at this point. The important thing to understand is know what your doctor's restrictions are for his total hips. If you're seeing Dr. May's patients, you need to know what Dr. May's instructions are for those patients. They will try to take minimally invasive approaches if possible, but it's not always possible. For a total hip replacement, you've got to open up. You've got to do a full open reduction of that hip. Closures. They can do staples on the hip, but a lot of times they're going to do sutures, right, or laser sealing. Understand what it's going to look like for those, what the care is going to be. Oftentimes, we're going to be the ones that have to give them instructions on how to care for their wound because the nurse didn't. And so we're going to have to tell them how many times, how often are they going to change their dressing? Are they going to change their dressing? And again, this happens where people aren't told to change their dressing, so they'll go out of the hospital. 5 days later, they're seeing for their follow-up, and they have the same dressing they were in when they came out of the hospital. And they're like, well, why didn't you change your dressing? Well, no one ever told me to. And so the doc's like, oh, son of a... So what can be some complications? Well, anytime that we put a patient under for surgery, that patient can die, right? Anytime that you put a patient under an general anesthetic, death is a real possibility. You can give that person enough anesthesia that the actual brainstem stops functioning. It's 100% a complication that can happen, right? Anytime during the surgery, they can nick the femoral artery. Yeah, usually malpractice at that point, right? They can nick the femoral artery, or they can nick the posterior vein. It happens, unfortunately. You know, surgeons aren't perfect. And again, I told you multiple times, they're doing 10, 20 of these surgeries a day. I imagine maybe the first 2 aren't the best, then by 3, they're good. And by the time they get to 7 and 8, they're starting to get worn out of doing these surgeries. And, you know, just think of yourself, right? Think of how you go through your work day. Usually when you first get to work, things kind of suck. Then you get into a rhythm. And then the closer you look at that clock and see that exit time, it kind of starts slacking off again. Same thing's going to happen to a surgeon. It's just a natural process of humans. It is possible for them to leave tools in the surgical site. I've seen left sponges. I've seen scalpel blades left in. I've seen tools where somebody left a retractor in. All of that's possible to happen during surgery, and it's not uncommon. The really kind of not uncommon thing happens with post-op, and that is infection. Yeah, no one in the room noticed that they left a retractor in. I don't know how that's possible, but it happens. Right? And a lot of times I think it happens because most of the times the surgeon comes in and does the surgery, and then oftentimes their attending is who closes the surgery. So as soon as they're done getting that everything put in place, they scrub out and are on to the next surgery, and their attending, which is one of the doctors in training, closes up the surgery. So I think that handoff sometimes happens. Have you never watched Grey's Anatomy? No, actually, I've only seen like the first episode of it. I think was the only time I ever watched it, and I'm like, no, I'm never going to watch this again. But it's really common for patients to come out of hospitals with surgery infections. That's great. Post-op infections are way, way, way too common here in the United States. Did Dr. Sokel talk to you about the post-op infection rate in pathology? The nosocomial infection rate, right? Do you remember what it was? Yeah, like 1 out of 20, 1 out of 25, depending upon where you're at, right? So that's not exactly a reassuring. So, you know, it's about a 4% chance, 4 to 7% chance of going in for a surgery and coming out with an infection. Think about that, right? If you go to other countries, like even, it says, but even going to Mexico, it's about a 1 in 500 chance. I used to wonder why. I used to wonder how we ended up with all these infections. And now I see people being babies about wearing a mask. And now I don't wonder why anymore. Right? I don't wonder why we can't stop hospital-acquired infections. This is just why, right? And not only that, but patients are babies, right? They come out of surgery, and a lot of times they're not going to do what they're told, so they're going to develop that post-op infection afterwards. Let's say that I have a total hip replacement, and I get a massive MRSA infection of the hip. So maybe for whatever reason, one of the nurses didn't wash themselves clean enough, or one of the docs didn't, and you got a little bit of their MRSA in the actual wound. And now that wound gets infected. Now the prosthetic gets infected. Does anyone know what they have to do for that? If your prosthetic and everything gets infected. More than redo it. Well, they may have to amputate if it's bad enough. But a lot of times what they're going to have to do is go in and pull out all those prosthetic parts. So they're going to yank out the femoral component, yank out that acetabular component, or if it's just one, they'll yank out that one. And then they're going to put what's called a medicinal spacer in. And a medicinal spacer is just this kind of gooey sponge that they put in place of that prosthetic, and they're usually going to leave it there for about 6 to 8 weeks. Well, it depends. It depends. Doctors are going to try to get you to pay for it because they're going to say you didn't follow their orders, so you caused the infection. Right? That's where you have to hopefully have a good lawyer. But so they're going to put this medicinal spacer in. So they'll basically yank your hip out and put in a sponge and replace your hip. You are now non-weight bearing on that hip for 6 to 8 weeks. What happens is as you're moving around and your pelvis moves, and the same thing can happen at the knee. We'll talk about that with total knee replacement. That sponge is getting squished. And inside that sponge, there's an antimicrobial and antibacterial stuff that gets released into the area. But the other part of it is when it gets squished a little bit, it expands back out and it sucks up all that bad crap. Then after about 6 to 8 weeks, they'll go in, they'll reopen you back up, they'll take that sponge out, and then they'll re-prosthesize your legs. They'll put in new prosthetic pieces. And hopefully, then you come out and you don't have an infection. But by that point, you've now had 3 different surgeries on that hip. And all of that tensile strength of the skin around your hip is useless. Right? So what I'm saying is don't let yourself get post-op infections. That includes if you have an incision, right? When you've got an incision, you've got to be paranoid about that incision. You've got to make sure you keep it clean, you keep it in a nice warm environment, but you keep it protected. Late complications. After surgery, again, we talked about metallosis. That's a real possibility where you get those metal shavings. Maybe they just, you know, it happens where a doc has a 45 socket acetabular component and grabs a 48 socket hip. And now that socket's bigger than the acetabulum, and so now it's rubbing constantly, and those little pieces are just kind of flaking off, right? That happens as well. It's really common for patients to re-dislocate their hip after surgery, right? I had this one patient that we actually had a lawsuit about a few years ago. The first hospitals I worked at here, and he sued the hospital, he sued the doctor, sued the rehab company because the rehab, we weren't part of the hospital, we were a separate rehab entity, and then sued every therapist that saw him. And why is that? He intentionally dislocated his hip 9 times while he was in the hospital. Intentionally dislocated it. How can I tell he was intentionally? He was in the posterior hip and he sat like this in this chair. And swore up and down. Nobody ever told him not to sit like that. So he'd come in to see him. He'd be sitting like that. We'd palpate, and you could feel the head of the femur out of the socket. So they'd have to call the surgeon. The surgeon would have to come in, pop it back in. I just imagine it's got to be painful. I don't understand why he did it, but then he sued us for it. So what do you think kept our therapy? You have to, yeah, exactly. Well, here's the thing. Our therapy company and all of us therapists didn't pay him a dime. Do you know why? We documented in every single note. Talked to patients about posterior total hip precautions. Patient recalled 1 out of 3. Reviewed remaining 2. So every note was documented that way. And they really tried, when I went in for my deposition, they tried to hang me up on this. Because they're like, well, tell me about working with Mr. Martin. And I'm like, well, can I see my notes? Because this was 3 years ago. You know, what they're trying to get you to do is say something that is, you know, it's culpable, and they don't want, you know, you don't want to do that. So I kept saying, well, all my stuff is in the notes. All my stuff is in the notes. Let me look at my notes. And when I looked at my notes, sure enough, I documented and went over stuff. So documentation is key. Therapy department paid nothing. Hospital paid him $400,000. And the doc paid him another, like, either $250,000 or something like that. So he ended up getting like almost $800,000, $900,000 out of it. Right? Why do you think they paid? What's cheaper? Yeah, it's to get rid of them, right? It's cheaper to pay the lawsuit off than it is to go to court and get the bad publicity. Right? Bad publicity is worse than anything that anyone can ever do. And of course, this guy was threatening the whole time. I'm going to go to the press with my case. And if I was the hospital, I'd be like, I'm going to go to the press with how much of an idiot you are. But they didn't do that. They paid him. Right? So when they have those hip precautions, the reason they're given those hip precautions is because those hip precautions are to keep them from dislocating. If you don't take care of that and make sure that you're covering what the dislocation stuff is, that can lead to some major problems, right? So you want to make sure that when you're talking to that patient, you cover those post-op precautions. Say, okay, so, I want you to remember, what are your hip precautions? And the patient's like, oh, remember my hip precautions. And you're like, okay, well, your hip precautions are no external rotation, no internal rotation, whatever it is. And you go over them again with the patient. And you go over them again with the patient. And you go over them again with the patient until you can recite them from memory. Because that is literally what's going to allow you to avoid getting sued. So and then after you recited them from memory, you document it. That's why we do all of that. If a patient is a habitual dislocator, what do you think about the stability of that joint? Is it going to get better or worse? So that guy dislocated his hip 9 times. Well, the more he dislocated it, the easier it got, right? Because he kept stretching those muscles out to the point where now it would just dislocate. So we want to make sure we're paying attention to that. Leg length inequality, we talked about that with how to measure, but a lot of times when a patient comes in for total hip replacement, they're going to measure the contralateral leg. They will also put in big black letters on that leg, not this leg, because it happens all too frequently. A patient comes in for a total right hip replacement and comes out with a left total hip replacement. I don't know how that happens. I can't explain it to you guys. Yeah, exactly, right? So and a lot of times, so when I'm not joking, they will literally take on with big Sharpie, and they'll be afterwards, they're sitting there in their hospital room going, why do I have Sharpie on my good leg? And you want to tell them, well, you have that so that the surgeon didn't accidentally do surgery on the wrong side. But if you say that, it makes the surgeon look like an idiot. Like, oh, right? They do that a lot. They'll wrap the one leg in betadine as well, so the one leg will be orange to know that that's the leg to use. But understand, when they go in, they're going to measure that good leg. Once they measure that good leg, they're going to set the other component up. Which one was it? What do you mean? Oh, wait, hold on. They didn't on my shoulder. I thought it was. Yeah, right? Exactly. How? How is that possible, Dylan? How, if you have the patient's chart, do you not know which side to do surgery on? I just don't get it. I had one doc, yeah. I had one doc once that I remember one of the nurses says that every time that he walked in, he did this to tell which side was the right and which side was the left. And I'm like, I thought that was dumb. But then I thought about it. I'm like, well, I mean, I guess he's making sure he gets the right side. I don't know. I've done it once in my career where I've worked on the wrong side. I went in to see a patient, worked on their right side, did all their exercise on the right side of the right leg, and the patient at the end of the session goes, it's my left leg I had surgery on. And I went, yep, I just wanted to even you out for the day. Oh, well, that makes sense. And I walked out going, oh my God, I can't believe I did that. But I did that once. And it was because I didn't read the chart going in. I should have known better, and I've learned since then. Read the chart, read the chart, read the chart. But I just can't imagine. Like, I don't know if maybe there's that many medical errors that they come down and they're supposed to have a right hip replacement and the chart says left hip replacement. I don't understand it. I don't. But anyway, with the leg length inequality, when they go in and they do that surgery, they're going to make the legs equal length. So for me, if I go in and I have either left or right hip surgery, I'm going to come out, my 2 centimeter difference is going to be fixed. They're actually going to take the true leg length on both sides and make them match. That can be really unnerving to people when they come out of surgery, because they're so used to having that discrepancy that they've you've got used to walking that way. And then they come out and they're like, everything feels weird. Well, it's because, number one, you've had surgery, but it's also because now they fixed that leg length discrepancy you probably had, right? It happens really commonly in total knees where they may shorten up that femoral component a little bit, but it's really weird for the patient to feel. All right, let's take a break here. It's about time for a break. Let me get up my good old timer here. I can see I'm starting to lose some of you, so let's take a break. We're going to pause. Resume recording. All right. So we're going to go back here to start back along the idea here and what we're doing. Post-op. Patient comes out. If they're immobilized, it is going to take the recovery and lengthen it. Any immobilization, we've talked about this before, any immobilization is going to lengthen the recovery. So that means we never immobilize patients. Absolutely not. We may immobilize patients, especially if we have somebody that, you know, they're more apt to dislocate or something to that effect. There are times where we will probably immobilize patients. I never forget, I had one. She was total hip replacement. She was in her late 40s. And man, anesthesia did something weird to her. I don't know if I've told you the story, but this lady it was funny, but it wasn't funny. Because anesthesia messed her up for a good probably 3 weeks. So much so that she had to go up to the psych floor. She came out of surgery and had a real bad reaction to anesthesia. They moved her to the ICU because her heart rate was going between 20 and 120. It was just vacillating between them. That was the first part of it. Then she comes up and she's conscious, and she is convinced that her husband is not her husband and that the aliens have replaced him with an android. So she actually signed rules that would not allow her husband into the room with her. He would be out in the hallway and look at her, but he wasn't allowed in the room with her because when he was in the room with her, he was reading her thoughts and stealing her thoughts. Also, every time the phone rang at the front desk in the ICU, the phone turned on a magnet on the ceiling, which magnetized her hip and lifted her hips off the bed. And was the goal to cause her pain. And then yet the best one is the reason she couldn't walk is because if she walked, she would have to open her legs, and if she had to open her legs, flies would fly out of her vagina. She would only trust me. She would not work with anyone else in the hospital in PT or OT. She would only work with me because she said that I believed in the alien theories of replacing people. And I don't remember ever saying anything like that, but for some reason, I was her Fox Mulder, and she wanted me for therapy. That included the re-eval where the PT had to stand out in the hallway and tell me to do everything because he wasn't allowed in the room because he would read her mind. And it's a true story. She was in for a total hip replacement. This happened, completely normal lady coming into the surgery. She had to go up to the psych floor for about probably 2 weeks. And then something happened 2 weeks into it where all of a sudden those meds turned off. And she woke up one day and she's literally, why am I on the psych floor? What is going on here? And she's a teacher. I remember she was a teacher, that's right. And she's like, why am I on the psych floor? What is going on? Where's my husband? What is going on here? And like the nurses try to tell her all this stuff that, you know, this is what you did. This is why you're on the psych floor. She had no recollection of any of it. Think about that for a second. She lost 3 weeks of her life because of anesthesia. That's totally wild, Tyler, right? 3 weeks of her life wiped clean from her slate, gone. I mean, I'm hoping gone. I'm hoping she just didn't repress it because she was like, man, I was an idiot. Right? But it's just completely gone from her memory because the anesthesia just sent her on this bender. Right? And they initially thought that because they were giving her Demerol, right, which is hydromorphone, and they thought, well, maybe the Demerol is causing it. So they switched her from Demerol to Advil. Still same way. So it wasn't the Demerol, it wasn't the pain meds. But I remember the first time I saw her on the regular Gen Med floor, they had moved her from Psych down to Gen Med. And I went in to see her, and she's like, I remember you. She goes, you've spent a lot of time with me in here. I'm like, yeah, we've spent a good bit of time. You know, she was ordered for an hour of therapy a day. So spending an hour with her was loads of fun. Let me tell you. And she looks at me, and I'll never forget, she just looks at me, and her husband's sitting in the room at that point, and she's like, I'm sorry. I don't know what that was, and that was not me. So I really apologize. She goes, the things they told me I did and the things I said, I'm embarrassed. I don't know what to say. But that was a post-op problem from anesthesia, right? So those type of things, and we had to immobilize her because, well, she was acting kind of crazy, right? Weight-bearing considerations. All of that's going to come on to the doctor, right? So let's talk about weight-bearing restrictions real quick. So we're going to change. No, blue is not a good color because we couldn't see it. Let's do white. White should show up. All right. So what is the best weight-bearing restriction a doctor can give a patient that you would see? So a patient comes in for surgery and the doc says, this is their weight-bearing restriction. What is the best weight-bearing restriction you could see? Have you guys talked about this in rehab yet? The weight-bearing type stuff? I'm going to take that as a no. So the best thing you can see on a patient's chart is FWB. Now, that does not mean what you think it means. Some of you are going, what? This is medical terminology, not personal terminology. Right? So FWB, you can have WBAT, and we'll talk through all of these. Good, we got full weight bearing. So these are the ones you can have. So FWB we got is full weight bearing. What is WBAT? Weight bearing is tolerated, right? What's PWB? Partial weight bearing, good. See how these classes come back together? And what's TTWB? Toe touch, right? Now, most times if we go up here to partial weight bearing, it'll say something like this. Partial weight bearing, 10%. Because it tells you how much weight they can put on. I'm going to be 100% honest with you, and this is coming from Mr. McKeever's heart. Partial weight bearing is almost impossible. I hate when I see somebody coming out with partial weight bearing. I would rather the doctor order toe touch weight bearing. I can explain that to a patient. I can't explain a 27.5% partial weight bearing status to a patient. Doesn't work that way. I can explain toe touch. So if the patient comes out full weight bearing, how do you tell them? What do you tell them? How do you tell them how much weight they can put on the foot? So I'm your patient. What would you say to me? You see me walking, I'm kind of gimping along and not putting weight on my foot. What would you tell me? Yeah, so for either weight bearing as tolerated or full weight bearing, you're going to tell me the same thing. The doc fixed your leg. You can put as much weight on, it's going to support you. And why are they doing that limping and not putting weight on it? Well, number one, they're putting no weight on it because it probably hurts, right? The other thing is test it out, right? They're not so sure about this leg yet. So you need to be that person that comes along and goes, nah, man, right? Nah, man, fixed, yo. Like, rock it, bruh, right? No, don't do that, right? Be like, the doc fixed that leg. Everything's good in it. And explain to them, the more that you put weight on it, the better it's going to feel. You know, I want them to make full weight bearing. If weight bearing is tolerated or full weight bearing mean the same thing to me. Put that leg down and put your weight through it. Because that means that the doc is confident in the surgery enough that it will get better as the patient walks. Partial weight bearing is pain in the butt. I did cross it out there just because again, this is anecdotally and this is my personal experience. I don't believe in partial weight bearing because the way you have to do this is you have to get them to full weight bearing first and then tell them how much they can't weight bear. So you're going to have to stand them up, put a scale under that foot, tell them to put all their weight down onto that foot, find out how much weight they put down onto that foot normally, and then take that scale out, calculate out how much is 10, 20, 27.5. I had one doctor that used to just do that all the time. 33.4% weight bearing or partial weight bearing. 33.4? Right? Well, what it was doing is he was calculating out, he'd be like, the patient weighs 250 pounds and I only want 25, 30 pounds of weight on that leg. So you divide the 30 pounds by the 250 pounds the patient weighed and we'll come out with the percentage of that weight. But I'm like, James, come on. We got to talk about this for a second. Right, exactly. That would make more sense to me than 33.4% weight bearing, right? And I said, James, come on, dude. Let's talk about this for a second. And he's like, the best part was he goes, wait a minute. You're a PTA and you're talking. Why has no PT, no nurse, no other doctor said anything to me about this, and you're willing to come up and talk to me about it? And I'm like, well, I guess I don't value my career as much as everyone else. I don't know. I'm not scared of docs. I guess that's what it is. But yeah, like, really, that's just the truth, right? I mean, like, 33.4%. Come on, doc. And James, if you ever catch this, I'm sorry, but I'm calling you out on it. And then toe touch weight bearing. So let's say I come out and I'm toe touch weight bearing. Well, the reason why I'm toe touch is they want the patient to have the ability to balance with that leg, but that is all. They want a little bit of weight, enough to kind of get that approximation of the joint, but not enough to put weight through the joint. So how would you tell somebody that was toe touch weight bearing how much weight they can put down? What do you think? What's your idea? Okay, test out while holding on some. Good. Okay, that's an idea. But what would you say physically to them? Like, you're the PTA now and I'm your patient. How would you explain toe touch weight bearing to me? I know this is making you work and have to think. Sorry. Touch the ground, toe. Okay, that's fair enough. Minimal weight. Okay, good. But my minimal weight and your minimal weight, though, remember, Kelly, could be very different. I have a real good phrase I like to use with this. What I'll tell patients is, okay, let's stand up, and I want you to put your toes down. What I want you to imagine is that you have an egg under your foot. And you can put your foot down and rest your foot on that egg, but you don't want to crack the shell. Does that give you a pretty good idea of how much weight you can put down? Right? Yeah, it actually makes sense, right? Or in a patient, yeah, walking on eggshells. Exactly, right? Or the other thing I'll say is, imagine I made the floor is covered in bubble wrap. And you want to put your foot down, but you don't want to pop the bubbles. any of those works, right? That gives us, what that has done, and this is a psychological approach, what that has done is that's put a picture in the patient's head, right? If I say, walk gentle, right? Yeah. If I tell you the floor is covered in bubble wrap and you don't want to pop the bubble wraps, tell me most of you didn't just see a floor covered in bubble wrap. Usually they're going to be with an assistive device, or you. Right? So, but that just helps them. That gives them that visual impression, right? Walking on eggshells is a great one. We've all heard that, right? When your significant other's mad, you're walking on eggshells around the house. Same idea here. That's toe touch weight bearing. But yeah, so most of the time, anytime that they're any of these, they can be with an assistive device, right? Especially toe touch weight bearing. But if you don't have the assistive device handy, or they haven't been assigned one yet, that means guess who becomes the assistive device? You guys do. There is nothing that says you can't become a walker for a patient. Right? Can I not put my arms out and give them something to put their arms on? That's where the gait belt's handy. Yep, exactly, right? There's amazing ways that you can do this, because maybe you don't have the walker handy and you got to get them out to the bed. Well, you could just sling and toss them like you guys were going to be learning in transfers, right? But it's much more functional to get them up, have them take little steps like you're their little walker, and sit down. That preps them for getting ready for a walker. So now let's talk about those assistive devices real quick, because you're going to talk about this in Dr. O'Neill's class. I don't know if you've gotten there yet or not. Let's talk about assistive device progression. There we go. So number one, what is the most safe assistive device you can put a patient in order to walk with them? There's one more safe than a walker. No, not by far. No. There's one that's usually mounted to the floor. Parallel bars, yes. Right? So parallel bars are your friends. What is the abbreviation for parallel bars? Does anyone know? Good, right? And I usually do put bars behind it, right? I've also seen it as, where's my P-bars as well, but that's not an official abbreviation. That is the abbreviation for parallel bars. Parallel bars are your safest assistive device because they're not going to move on you. So that means you've got somebody you're worried about, the total hip replacement. You're not sure if they're going to have the strength to stand up. You're not going to be sure if they have the strength to walk. Get them to the parallel bars. That's your safest assistive device to use. The next safest, who said it here? Kana said it, is walker. But what type of walker? Standard first. We always add wheels second. So standard, or what's the other term for a standard walker? Does anyone know? A 4-point walker. Right? So a 4-point walker is the one that just has legs. That's kind of the next safest thing. Now you can filter in here anywhere, right? Technically, you are really the safest assistive device they can have because you have total control over them. But I'm still going to have them in the parallel bar because eventually we have to get them to walk with the assistive device. So now your patient's gotten better. Now you can move to a front-wheeled walker, right? When you add a wheel to a device, it takes away safety. Does that make sense? But what does it add? It may take away some safety, but it increases their ability to do what? Move normally, right? Yeah, because think about it. If I've got a walker, 4-point walker, I've got to pick it up, step, step. Pick it up, step, step. With a front wheel walker, I can leave that walker on the ground and I can start walking normally, right? So the 4-point walker is never going to help you with mobility, but it's going to help you with stability. And we learned before, we want to be stable before we are mobile, and then we can become hostile. All right. So from the front-wheeled walker, let's go down in stability a bit. What can we go to next? Okay, yep, we can go four-wheel. I didn't even think about that, but that's a perfect, yeah. So four-wheel walker. We certainly can go to a four-wheel walker. What's the other term for a four-wheeled walker? What's the Cadillac that all the old people want with the seat on it? Does anyone know what the term for that is? It's called a rollator. Right? And I actually have seen now, have you guys seen the ad for the upright walker yet? I'll have to see if I can find it so I can show you it. I actually am in favor of this walker. They have a new walker called the upright walker. And the upright walker isn't one where we grab here, it's one where we grab here. And the walker actually comes all the way up to the chest. I actually really like that because I'm thinking about it, that's going to force me into extension and stand up tall, isn't it? Because number one, if you ever want to see what's wrong with people's assistive devices, go down to Sam's Town and sit down there for about an hour. And just watch all the little old people walking by with their assistive devices. Right? Because their walkers are down around their knees and they're walking hunched over. And you just want to run over and fix the walker for them. I've actually done that. And it's funny, my ex-wife used to get embarrassed by me all the time because I'd see this little lady walking with her walker way hunched over and be like, "Ma'am, can I fix your walker? I'm in physical therapy. Can I please fix your walker for you so that you don't have to hunch over as much?" And so I'd get it set up and she'd be like, "Oh, that feels better." I'm pretty sure like 5 hours later she changed it back anyway, but at least for those couple hours, she read it right. All right, so we got our four-wheel walker or rollator. Canes are always going to be our last resort. So we go from walkers down to what's the next step down from walkers? Instability. Pretty much the traditional assistive device of young people. And when I say young people, I mean under 65. What do we give somebody that breaks their foot? Crutches, right? And we can choose between axillary or forearm, right? Let me expand this a little bit because I'm going to forearm crutches. I'm actually going to type that out so it doesn't confuse you. Does anyone know what the other term for forearm crutches are called? Canadian crutches, good, right? There's one more term for them. Lofstrand. I'm pretty sure that's the guy that originally came up with them, but I can't guarantee it. So Lofstrand crutches. And again, we can choose, we're going to start with 2, and then we can go down to 1 crutch, right? 2 is more stable, 1 is less stable. And then finally, we can get down here to 6, where we can start talking about canes. And we can talk about 2 canes, 3 canes. We can talk about a 4-point cane. We can talk about a 2-point cane. The only cane that I will never, ever recommend to a patient, have you guys seen the Hurricanes yet? I have a problem with them. The point of having a cane is having stability. I like the idea that the cane can stand up on its own. I actually like that idea. But the fact that it weebles and wobbles at the base, although it promotes a little bit better, more functional gait, you've added a level of instability. Right? So like it just adds, so it has ability in the base of the bottom kind of rotates and rolls around. Why? Our canes work just fine. All right. So we've got a kind of, does this make sense for the progression of assistive devices? I know, so that when you get, because have you guys had assistive devices? Talking about the team. What's the team? I don't. Oh, the Hurricanes, yeah. They're unstable too. You're exactly right. But you know what? They have fun being unstable. Not as much fun as Carolina, but all right. So this is going to come into play. I know Dr. Sokel is going to talk to you guys about this, but this will come back to haunt you in her class. I guarantee it. So you guys already got a little preview. Now, she may switch canes and crutches around. It depends upon your PT, but this is the traditional progression I've seen. So weight-bearing restrictions. Okay, so we've covered assistive device progressions. Let's also cover gait patterns real quick. And you're going to cover this in her class too, but we're going to give a little preview of that as well. You covered these already? Okay, we're going to review them because it's important. All right. And I know that I'm going to, and I beat, this comes back to me teaching both these classes, so I beat these both in at this point. So 4-point gait pattern. What do you remember about 4-point gait pattern? Mainly with crutches. Good, right? It can also be with canes, but mainly with crutches. So the progression is this way. Assisted device, opposite leg, assisted device, opposite leg, assisted device, opposite leg, assisted device, opposite leg. So it goes assisted device leg, assisted device leg, assisted device leg, assisted device legs, and you alternate, right? It's the OPP leg. No one? Okay. In order to have 4-point, you either have to be full weight bearing or weight bearing is tolerated. Right? If you're partial weight bearing or toe touch weight bearing or not, oh, I forgot to put that up there. We also have non-weight bearing, right? Forgot that weight bearing pattern. See, no one caught me on that. You can't do a 4-point pattern. So again, 4-point, and here's the deal. When you're starting off 4-point pattern, does it matter what crutch to start with? Not really. Most times you're going to start the one opposite the affected leg, then the affected leg, then the crutch, and then the good leg, then the crutch, then the affected leg, then the crutch, and the good leg. That's kind of the way. Does that make sense? 4-point at least makes sort of sense to you guys? What's the problem with 4-point pattern? It's time consuming, good, right? It also requires what? It requires a good bit of coordination and cognitive ability, right? And strength. You're right, Adrian. I didn't really think about that, but you're right. It does. It requires a good bit of strength. But the main thing is it requires coordination and cognition. Let's say I've got a patient that's got a traumatic brain injury, right? And his brain's just scrambled. If I'm telling him to do this pattern, he's going to swing at me with the crutch, right? So 4-point may not be the best. So let's get down to 3-point. When you see 3-point, I want you to think non-weight bearing. 3-point should always be non-weight bearing, or it's also the traditional crutch method. So this is where your one foot's elevated off the ground, right? Assistive devices, hop, right? Assistive devices, hop, assistive devices, hop. So I also think of this as the bunny pattern because you've got to hop to it. So it's assistive devices, both, right? Bilat. And I need to make more space here. And then good leg. And we really got to get out of the habit of saying good leg versus bad leg, but it makes sense to the patient. We really should call it affected leg versus non-affected. But in reality, good leg versus bad leg makes sense to patients, especially when I'm dealing with kids. Saying affected leg to a 5-year-old is like saying onomatopoeia to a 5-year-old. They don't understand what affected leg means, right? They just know they can know which is their bad leg and their good leg. Happy leg and sad leg works too. Yep, absolutely. I've done that before with patients. Okay, let's bring the sad leg along. And every time we step with that sad leg, what's the sad leg becoming? It's becoming a happy leg. Don't you want me as a therapist? All right, the 3-1 or the mod 3. When you see this, I want you to be thinking partial weight bearing or toe touch weight bearing. And toe touch, not so much. This is where you're going to move the bilateral assisted devices plus bad leg and then the good leg, right? So where's my little... So let's just pretend I'm going to tie this off on my right leg just because this helps give us a visual. So my right leg is my bad leg. So if I'm using a 3-1 pattern, I've got my 2 assisted devices, right? I'm going to move them plus the leg, and then my good leg. Them plus the leg, my good leg. Does that make sense? And again, I know this is a review, and if you're bored with this review, too bad. This is a big chunk of your boards because you have to know how to train people on how to use devices. 2-point pattern. Good. 2-point pattern, I want you to think of cross-country skiing. Because that will help you remember it. So you move opposite AD plus opposite leg, op AD plus op leg. This is why I had you remember cross-country skiing. Oops. Oh no, I'm losing my flag. All right. So if I get 2 assisted devices, 2-point pattern is here, 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 here. That is what it looks like if you're cross-country skiing, if any of you have done it, all right? It's almost like you're walking normally, right? So I've got maybe I've got 2 lost strand crutches, right? Lost strand crutch and this leg. 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 Does that help with 2-point? Are we too legit to quit? Do we got that one? Good. Now, the mod 4 or the 4-1 and the mod 2 or the 2-1. I don't know where this 2-1 and 4-1 crap came from. Sorry, did I say that really? Honestly, I would rather just delete that 4-1 and delete that 2-1. I don't know where it ever came from. But some books teach it as the 4-1. And I think it's because they're saying it's the 4-point pattern with 1 assistive device. And this is the 2-point pattern with 1 assistive device. But it's really confusing. Mod 4 and Mod 2 make more sense to me. So remember, with either of these, you're down to 1 AD. So with Mod 4, it's going to go AD, op leg, good leg. And with this, it's going to go AD plus op leg and good leg. So let's go through the mod 4. Because remember, the regular 4-point pattern, we're back here. assisted device, bad leg, assisted device, good leg. The mod 4 or the 4-1 goes assisted device, bad leg, good leg. Assisted device, bad leg, good leg. So boom, 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 boom. And then the mod 2 just takes the 2 point, gets rid of one of my canes. So now I'm assisted device and bad leg, good leg. Assisted device and bad leg, good leg. Assisted device and bad leg, good leg. So that's all the standard gait patterns we can do. Except we've got one that we didn't really cover, which is normalized gait. Normalized gait just means you do what? You walk. Who is going to help determine what gait pattern to use for the patient? Who's the primary determinant of that? The PT, right? He's going to essentially decide. Now, a lot of times what the patient, you'll see on the PT's chart, the patient's eval, is it'll say something like this: ambulate, patient, appropriate gait pattern, LRAD. This is the best thing as a PTA you can ever get. So ambulate patient, appropriate gait pattern, LRAD. What does that mean? If you see that on the eval. Translate PT speech. Does anyone have an idea or want to take a stab at it? Yeah, right. Not left, right. So what they're saying is, you choose PTA. Use your best judgment because you're going to see the patient longer than me. Right? So it's going to say, see the patient, figure out what gait pattern's best for them, and what does LRAD mean? Doesn't mean left, right, assisted device. That's a good guess, though. Does anyone know what LRAD means? It's a really good guess. That's the first time I ever had that guess, by the way. Least restrictive assistive device. So what that's saying is the PT is not telling you to use a cane, not telling you to use a walker, not telling you to use the parallel bars. They're giving us the freedom to pick what's appropriate for the patient. To me, when I see that, that tells me my PT respects me, right? That tells me my PT is saying, I trust your judgment. And believe it or not, most PTs in the world are going to write that. 2 reasons. Number 1, they trust our judgment. Or number 2, they are not trained enough in assistive devices to know which one's best for them. I'll be honest, with most assistive devices, the PT has spent maybe an hour, maybe 2 hours with assistive devices. They don't get a lot of time. And even like, what do you call them? Modalities. PTs get barely any training on modalities. They spend a lot of their time on theory and research and don't spend a lot of time on this anymore. So a lot of times PTs are going to come and go, you know, I don't know. I don't know what to use for this patient. Figure it out. That literally says, figure it out, PTA. Does that give you a really good kind of overview when we're talking about post-op, what kind of assistive devices to use? Does that help? I wrote really all over the screen, didn't I? All right, and like I said, this is getting recorded, so you guys can go back and review this. I'm going to clear the drawings now. Exercise progression. Let's kind of talk a little bit about that. So when they come out of surgery, again, they're in that acute phase of injury, which means that the first stuff we should start doing with them are isometrics, right? So glute sets, ham sets, quad sets, you know, abduction squeezes, stuff like that. Then progress to mobility type exercises. The problem is when they're in the hospital, we don't have the We don't have the liberty of spending a ton of time with them. Most times in the hospital, when you see a patient with total hip replacement, you see them twice a day for a half hour at a time. Half hour at a time is not enough to get them completely healed, right? If we get that to rehab, where we're talking about accelerated rehabilitation at the bottom, where we're spending 3 hours a day with them, yeah, then we have time to really kind of drill down to the nuances. But most time in the hospital, our job is just to get them good enough that they can get out of the hospital. We're not going to have a ton of time with them, right? Most times that I've seen them in the hospital, again, I'm using generalizations with most, I see my total hips and my total knees in a group setting for exercises. So we'll all do the same exercise. I'll have 10 to 12 patients around me. We're all doing the same exercises. I probably spend about a half hour doing exercises with the whole group. And then I spend a half hour individually with each patient. So they might get an hour of therapy, but really that group therapy is not one-on-one, right? That's me with 12 other patients, and I'm not going to catch everything. So they might get an hour of total therapy a day. Almost all of these total hips and total knees are going to be a BID patient, meaning they need seen twice a day. Maximum protection phase after traditional heart or hip replacement, right? Traditional heart replacement, that's good, is stabilization. We've got to get all those stabilizers in the hip back to function. So we've got to do a lot of setting. Again, glute sets, ham sets, quad sets, abduction squeezes or adduction squeezes, abduction slides, stuff like that. Once we kind of get out of that, now we can start getting into more of the, closed chained activities and getting them to do some weight bearing stuff like squats, right? As long as they don't break their precaution, maybe some side lunges. And then once we move past that, we're going to move to the minimal protection phase where they actually start getting back to normal activities. Patients can, if they've had a total hip replacement, return to sports. It seems a little kind of like weird that we would send a patient that just had a total hip replacement back to sports, but it absolutely can happen, right? They can absolutely return to sports. It's just going to take a little bit of modification on their part on the way they do things. Total hip replacement guidelines. So our precautions, or total hip precautions, THPs. How long does a patient have to observe no hip flexion past 90 degrees, no internal rotation, and no adduction of the hip for a posterior total hip? How long do they have to observe that? What do you think? How long do they have to completely avoid all of those positions? Okay, so 30 days, see 1 week. So if you look at the surgical guidelines, it says a minimum of 8 weeks. But most doctors with the posterior total hip, those precautions are for life. Anterior hip, I've seen where they'll do 8 weeks of precautions. But when it all comes down to it, it's the surgeon's choice. So when a patient asks me, how long do I have to not bend way over? My normal answer is until your surgeon tells you otherwise. Because we don't want to be the ones to tell them, oh, well, you're 2 weeks out now and you should be good. And they go and tell the surgeon, well, PTA said I can bend way far over. And then you get that phone call. Hey, Keith, this is James. Why did you tell the patient that? You know she's not standing with precautions anyway, and blah, blah, blah. And then you have to sit there and answer for it. Let the doc decide it, right? And if not the doc, let the PT decide it. That's why they go to school longer than us. That's why their malpractice insurance is more expensive than ours. They're trained to do that type of stuff. We're trained to do what they tell us to do. All right, pain relief. The biggest reliever of pain is what? What is the motion? Right. So the more the patient moves, the better they're going to feel. That doesn't mean that pain meds aren't a possibility, right? So motion is lotion. You're exactly correct. So that doesn't mean they're not going to see pain meds. So what are some pain meds you might see the patients on? Well, our most common that they should, the easiest ones they should be on are Tylenol and Advil or Aleve. Hopefully, Those are the ideal ones they're on because those are all non-narcotic, right? Now, does that mean they don't have any side effects? Absolutely not, right? Tylenol is acetaminophen, Aleve is ibuprofen, or I'm sorry, Advil's ibuprofen, Aleve is naproxen sodium. Doesn't mean they don't have side effects. Most of them have GI side effects. But they're kind of the, okay, you're doing survive. Now, we get into narcotics, right? We have morphine, sulfate, hydromorphone, oxycontin, there we go. Hydrocodone, oxycodone. Spelled it right. And I think that's spelled it right. We'll go with it. So most of the medications you're going to get are going to have some brand name, right? But they all break down. Did I spell it wrong? Thank you. See, that's why I keep you guys around. That looks closer to right. Thank you. How do you know how to spell that, Jaira? Just kidding. All right. So up top, okay. We get down bottom here, we start getting into the addictive stuff, right? The stuff down here, how quickly can you become addicted to these meds down bottom? What do you think? Yeah, one dose can make you addicted to it. And if you see the way it alters your brain, again, I told you this before, to me, it's amazing. Right? Now, we could include down here as well, believe it or not, we can include that as a pain med too. Because originally, heroin was a pain med. So for those of you that study your history, morphine is what we gave, morphine's what we gave to people coming out of the Civil War. Right? And so then we found out people got addicted to morphine. And so we're like, well, we've got to find a less addictive version of morphine. And you know what we found? Heroin. And so we started giving patients heroin. And then guess what we found out? They got addicted to that. And so then we came up with the other ones, hydromorphone, oxycontin, hydrocodone, oxycodone, fentanyl. And all of those, we kept saying, these are non-addictive. And we keep falling for it. They're addictive. They're all addictive, right? The only one up here that's not naturally occurring is hydromorphone. Hydromorphone is which medicines? Anyone know what the brand name of that is? It's Demerol, right? And if you hear nothing else, Demerol, you hear a lot of times with sports athletes, well, I guess they're all athletes that are in sports, huh? But with sports medicine, you'll hear a lot of the athletes talking about, give me that shot of Demerol, because that's one that a lot of athletes abuse, right? But again, all of these are addictive and they all affect your brain differently. But they're all addictive. So how often should the patient be taking these medications down here? Well, first of all, they should be taking them as ordered, right? If it says take 2 morphine sulfates at morning for functional movement, they should only take 2. Well, why do they end up taking more usually? Why do patients start taking more of these drugs, other than addiction? Oh, methadone too, yeah. Well, methadones are, it makes them feel better, right? If then it can feel nice. I don't really care for the feeling, but I'm going to tell you from experience, when I had my broken neck, it was, right, it makes you work. I will say that when I had my broken neck, this was the only stuff that was making me functional, right? And what it was doing was completely masking my pain. I still had my pain. It was still there. The brain's still telling me, your neck's messed up. But at least with this, I could function, right? And that's where it starts. You're taking it to keep your function going. And then you build up tolerance. And then once you build up tolerance, you need what? more, right? So then you start taking more. And then you build up tolerance to that. And then all of a sudden, the surgeon's going to say at one point, no more morphine sulfate. And so they take you off of it. And then you do for a while, you're okay, and then you get the rebound. I should add one up here that I didn't think of as well. Ultram is another one that we can talk about. Why am I drawing a blank on what the non-brand name is of it, right? Tramadol. Right? That's a little bit less addictive than the other ones, but it's still slightly addictive. But all of these we use, and this all came out of the 90s when we started doing the idea that pain shouldn't be something we experience, right? All of these medicines down here, you know what all the lower ones, morphine sulfate, hydromorphone, all that was designed for? Does anyone know what they were all made for, truly? End of life, palliative, and then cancer pain care. That's what all these down here were designed for, was cancer pain care and end of life care. And now we give them out like candy, right? I had a patient once that came to me that had a total knee replacement, and I asked him, well, what kind of meds are you on? And he's like, hold on. So he breaks out his pouch and he sets them all on the table for me. And I'm not joking. He had a 320 pill bottle of OxyContin from his surgeon. And I'm just sitting there going, whoa, right? Whoa. All of this is great, but it hides the pain. The only way we can relieve the pain, if you ever, so Erica just said Purdue sales rep did a really good marketing. You're exactly right. If you guys ever get a chance, and I'm going to I highly, 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 highly recommend the book. It's called Dope Sick. Pick the book up. Hold on, let me see if I can remember who it's by. Because I've got it in my desktop. It's by Beth Macy. So I'll type it over here. It really goes into the whole how we got in this place that we're at now. And it takes a specific focus on Virginia. They were, right? Does anyone know who the first attorney general was that took Purdue to court? It was in West Virginia. He's kind of famous. He was the director of the FBI until he got fired. Well, actually, they both were. Both were directors of the FBI before they got fired. It was James Comey and Andrew McCabe. They were both the ones that brought Purdue kind of to their heels. But we're still in the same boat we are back then, right? But if you get a chance, read that book. I read that. I picked up the book. I want to say the book's like 212 pages. I read it in a day. It's literally, you just read through it, and it just, the more you read it, the more sick you get. But at some point we thought, well, you know, this pain meds up here aren't good enough, right? When I was in Denmark, I got hit by a car on my bike. This was when I was working there. So this would have been when I was 21, I think-ish. Car hit me at like 75 miles an hour. Absolutely destroyed my bike. Ironically enough, at that time, the only thing I was worried about was I was going to my girlfriend's house, and I was worried that I was going to be late to her house after I got hit. That's the best part of it. True story about that. Took me to the hospital, and they discharged me from the hospital. I was on loft-strand crutches for about 6 months because I had a partial fracture of my tibia. They gave me Tylenol. If that was here, you'd be going home with all kinds of opiates, right? So all these opiates aren't necessarily good. I'm not saying they're not useful, right? But you need to understand when patients are supposed to take it, how they're supposed to take it. A lot of times they'll be given like OxyContin and then told to take Tylenol for breakthrough pain. And we talked about that in math, how that can be a bad combination because they might overdose on Tylenol. But I'm just saying the best pain relief you can give your patient is motion. Get them up and moving. That is the true pain reliever, right? So much so that the APTA has a whole program designed around teaching PT over opiates and showing that patients get better on PT than they do on opiates. But that doesn't always listen for the docs, right? All right, so patient satisfaction. This is going to be both the benefit and the rulers of your life when you get to hospitals. Have any of you worked in a job where they send patient satisfaction surveys out? Or customer satisfaction surveys? I said I've worked in car dealerships. I sold cars for a while. And they send out satisfaction surveys, and those are going to rule your salary. So the more you make a patient happy about their care and understanding how they can do it, the better your patient sat scores are going to be. So patients really need to understand that the only way they're going to get better is not by what you're doing, but by what they do. Right? If they become dependent on you, you're going to have a bad patient sat score when they get home and can't do anything. The more independent you can make your patient, the better it can be. Quality of life, right? We may have to look at how to improve things in our home too. So we may have to go home and do a home eval. Physical functioning is important. How they do the implant design, fixation, surgical approach, all important. The key thing here, though, is if you learn nothing else out of this, is that rehab can have a direct impact on how that patient functions for the rest of their natural life. I've seen patients come in that have had a total hip replacement 6 months ago, and they'll come in for a checkup with PT. Right? I wish that we could do that more often, where they get, maybe after they've been discharged from PT in 6 months, they can come back for 3 extra PT visits, or they can just kind of fine tune them, right? Think about it. With your air conditioner, every year you should bring somebody in to kind of tune it, check it, clean it, get it working. Well, why don't we do that with our body? So the difference between a THA and a Hemi means what? What does yes, half, right? So a hemiarthroplasty is where they maybe replace the acetabulum but leave the femur. Or they leave the acetabulum and replace the femur. That is a hemiarthroplasty. Why would they do a hemi instead of a whole? What do you think the reason for it would be? Yeah, they don't need it, right? They don't need a hole, right? Maybe their acetabulum is perfectly fine, but they've got a crack in their femoral head. That needs replaced, right? Or maybe the acetabulum is just chewed to high heaven, but the femur is actually normal. And maybe the problem isn't the acetabulum itself. Maybe the femur is too big. Maybe they have femoral megaly, right? And maybe that femur head is just too big for that acetabulum, and they need to put a bigger acetabulum in there. All of that's a possibility. The hemiarthroplasties are going to have the same surgical approaches as a full arthroplasty. It could be anterior, it could be posterior, it could be lateral. So you're going to follow similar precautions. Usually the precautions don't last as long, right? But anytime they do a hip replacement, understand they have to dislocate that hip. There's no getting around it. They have to dislocate it. So the patient's always going to be in pain. But let's think logically about it. If I have a hemiarthroplasty, what do you think is probably going to happen down the line? Right? Yeah. The other one's going to need it, or you're going to need, on the same side, the other, so the femur's going to need it, or you may need the other hip done as well. So just think about that when you have those. Hip fracture. This is a big one for older people. If you look at this, fewer than 2% of hip fractures occur in patients younger than 60. This should be encouraging to you guys. Think about that. Less than 2% occur in people in your age, right? 50 to 65 has a little increase, right? But greater than 65, look at this mortality rate. Greater than 65 years of age, mortality rates are approximately 50% within the year of suffering the fracture. Read that. Think about that. If an old person breaks their hip, it's a 50% chance of them dying that year. Does that terrify anyone else in here? To me, I know they do a lot of fear mongering because I'm really good at it, right? But that's terrifying to me to think about. If I had, if I had a grandma, if I had even a mother, that at that point, they fall and break their hip, that it's a good chance they're going to die in that year. And then look at that, it goes up 4% every year after that. So say you're 65, you break your hip, you turn 66, you've now got a 54% chance of dying that year. Turn 67, 58% chance of dying, right? You get 20 years out, maybe you live to 70 to 85, those odds are not for you anymore, right? I mean, would you take a 50% chance of winning down at the casinos? Right? You know that if you pull that slot machine down there, your winnings are never going to be big, right? That's going to be like you put in a penny and you win 2 pennies. This is kind of the same idea. The casino's not going to take that risk, so we've got to be careful with these patients. We got to tell them the only way to prevent this death is getting up and moving, right? So here's the different types of fractures, and they're named if you look at them. Oh yeah, absolutely. I call the wheelchairs death machines. I don't say it to patients, but I personally call them that because once they're in a wheelchair, everything's going downhill unless they actively work at it, right? They don't call it the wheelchair 25 for nothing because you're probably going to put them out 25 pounds first year of having a wheelchair. And think about it, some of you, 25 pounds is half your weight, not half your weight, but quarter your weight. So they're named after where they are. So we have the intracapsular are the ones that are going to be inside the hip capsule, right? That's what an intracapsular fracture is, because here's all our ligaments holding this hip together, right? These are intracapsular fractures. And if you look, they're named for the fracture. Femoral head fracture. Subcapital, which means below the head. Femoral neck fracture. And then we go back, we get out of that capsule, and we're out here at intratrochanteric fracture. It goes between the trochanters. Subtrochanteric fracture. And then we have the shaft fracture. Out of all of these, I'd honestly rather have this shaft fracture. If I was, I'm going to be honest, if I'm picking my fracture, that's probably the one I'm going to want. Even though that's probably the most painful, they don't always have to replace the hip with it, right? So they can come in here and put a rod down the side of it, pin them, and boom, I'm back to function, right? But we get up here and we start getting fractures up here into the surgical neck, right? Now we've got to replace this whole head. We lose that subtrochanteric. Maybe we can pin that, but depending upon how it is, then we may not be able to. But anytime we get past this line here, right, we're going to start losing hip stability. So that's the other downside to it. That's why I'd rather have it honestly down here, because overall my hip stability is in place. I just got to fix the bone. Mr. McKeever's art class. Open reduction internal fixation. We talked about this. ORIF, right? What does that mean? First of all, open means they've done what? Had surgery. They had to lay it open. They didn't do it arthroscopically, right? And ARIF would be an arthroscopic reduction internal fixation, right? But I rarely see that. Open reduction. The reduction is putting the bone back to place. Internal fixation, meaning there are screws and pins inside of it, right? ORIF. There are a couple different techniques they can do. They can do an intramedullary nail fixture. They can do an in situ fixation, meaning it's in-site fixed. They can do a rod. They can do an ORIF, or they can do an OREF, right? What's an OREF look like? I don't remember if I have pictures coming up or not. Oh yeah, I've got some pictures coming up. Yeah, right? So let's look at this going down. So here is an OREF. So the fracture's in there, right? What kind of fracture is that again? Oh no, we just had that a few slides ago. That is going between the good. Between the notches on the outside of the bone. So that is an intertrochanteric, right? You have between the greater trochanter and the lesser trochanter. Yeah, it is, right? Intertrochanteric. So here, right, we've got an internal fixation because we've got a rod going down the side of the leg. We've got an intermedullary rod going into it, and then we've got nails and screws holding everything in place. But there's nothing on the outside of the body, so this is an open reduction, meaning they opened it, they reduced it, closed off that fracture, and they fixated it. Here is an OREF. Open reduction, external fixation, right? I don't know why I have internal on that. I've got to correct that. But this is a really common one to have when you had a really, really bad pelvic fracture. And the main idea of this is basically like a halo for the hips. It's to keep everything kind of fixated and not allowed to be moved. So we have these. How do you wear pants? Usually wear shorts. They do make, honestly, every time I tell a patient what kind of shorts to get, they usually come back with one thing. You want me to wear stripper pants? Yep. Right? You find pants that have the buttons on the side that you can button around it. And sadly, some of the places you can get that is if you go to a place that sells clothes for stripping. They usually have them. Walmart usually has them too, because I don't know why Walmart has them. Basketball warm-ups, yep, exactly. Any of that works. Yeah, sometimes you go in and the patients are just sitting in their underwear, I'm going to be honest. And the underwear is kind of around the fixators. Nothing like walking into a patient and he's just sitting there in his tighty whities. Gives you a mental image, right? Or they'll get hospital gowns and they'll walk around in hospital gowns all day. Women, it seems to be nightgowns is the most common thing you'll see patients in that have had those. So I don't know why men don't have nightgowns, but maybe we should. Post-op management, weight-bearing considerations. Usually if they're ORIF, internal fixation, they're usually weight-bearing is tolerated. Unless there's been some sort of a problem with the marrow itself, then they may be not weight-bearing. If they're OREF, most times they're non-weight-bearing. Well, that makes sense. We've got this big cage around the pelvis. They shouldn't be up and standing with it, right? If we have an internal or external fixation, it doesn't really change what we're going to do. We're going to try to exercise the muscles that we can move. So if a patient has that big cage around their pelvis, is there any reason why we can't do ankle pumps with that patient? No. We can do ankle pumps, right? We can even do some limited quad sets, ham sets, and glute sets, right? But we're not going to have the patient do heel slides. We're not going to have the patient do ab and adduction slides. So we've got to be paying attention when we're working with these patients, understanding what their educational restrictions are, or exercise restrictions are. Again, during those maximum protection phases, when you see maximum protection ever, you got to be thinking setting exercises, isometric exercises. They need to be in your head. You need to have them on your plate so that you're ready to go as soon as you see a patient post-op day one, getting them to do stuff to kind of stabilize that pelvis and stabilize everything. Most patients that have had a total hip fracture of some sort or something like that, they're going to need extended therapy. Because again, we've learned if they're 65 or older, 50% chance of death after that. So they should be getting extended therapy. Other stuff we can have, muscular tendinous impairments. They can have tendinopathies or repetitive trauma, just like of the arm. Patients can get basically a hip pain or a knee pain, very similar to something having lateral or medial epicondylitis from moving stuff. Most of you guys, people that are runners, know all the fun about getting lateral knee pain from running, from that IT band rubbing over that lateral aspect of the knee, right? We'll get more to that when we get to the knee, but the hip has the same thing, right? That's got to start up there so you can get kind of pain from that sliding over the greater troch. Trochanteric bursitis is pretty common, right? The trochanter bursa is there to kind of lift the stuff off the trochanter, and that can cause irritation, get swollen, and then the muscles are going to be tight. So as I was saying, sometimes you can get problems in the hip itself. Psoas bursitis, there's not much we're going to be able to do other than moving that leg around, because it's not like we can get in. Yeah, it is kind of weird, right? But again, the idea of a bursa is to allow for a nice smooth surface for that muscle to glide. So, I mean, most of our muscles have bursas. It's just we don't think about them a lot. Ischiogluteal bursitis, what they call Taylor's or Weaver's bottom. So this is from sitting in Taylor sitting. What is Taylor sitting? This isn't like Taylor Swifting. This is Taylor sitting. All right, so let's talk about sewing Taylor, right? So we got a couple of positions, right? Let me slide back here. If I'm sitting like this, what is this position called? This is long sitting or short sitting? Are my legs long or short? This is short sitting. Now I'm long sitting, right? My knees are straight, okay? So we got long sitting, short. I'm gonna actually do this on the floor because I can't do it up in the chair. All right. So now I'm long sitting. What do we call this? If I see somebody say Indian sitting, I'm gonna throw something at them. Crisscross applesauce. Good. This is what we've kind of had to, Native American sitting. We've had to kind of modify this. This is crossed leg sitting, is another term you can use. With kids, Adrian's right, we call this crisscross applesauce, right? Okay, so we got crisscross applesauce sitting. What does Taylor sitting look like? I don't even know if I can do it. We'll see if I can. Nope, I'm too tight. Oh, there. Taylor sitting. Although my foot's kind of down where it shouldn't be. It should be up on the knee. Right? That's where the feet are up on the knees. I think that's a yoga pose too. I don't remember what that yoga pose is called. Okay, Lotus. Thank you very much, Alexa. I thought it was obviously I need yoga if I can't get there. Right? Okay, so we've got those two seated. What's this position called? So you can see my back. Like you haven't set up any home kit accessories. Thank you, Siri. Some more short sitting. This is just kneeling, right? Or what we call low kneeling. What is this? If that was low kneeling, what do you think this is called? High kneeling. Good. And then the one we try to break every kid of. W sitting. Right? Oh, God, that actually hurts. So those are kind of all types of sitting we can have. I don't know why you'd sit in lotus position for a long period of time. Maybe Alexa can answer that for us. It's not comfortable. But lotus position is also Taylor position. And I guess that goes back to them sewing and sitting in that position. I have no idea. I can't sew. Somebody asks me to sew, I say, so what? But all of those positions that can have it. Why is W sitting bad? Because you've heard that, right? W sitting equals bad. Is it bad for adults? Let's go there. Is it bad for adults? Not necessarily. I mean, it's not comfortable. I mean, you saw it. Like after I was sitting W sitting for about 3 seconds, I'm like, oh God, that hurts. My hips aren't used to it. But it's not as bad for adults as it is for kids. Growing kids is the problem, right? Especially growing what? Girls. Right? Because of that change in femoral angle, you can actually end up with dysplasia of the hips. It's funny. You saw my nieces the other day when I was on, and the older of the two, because so the older of the two, actually Elise is the youngest one, and Elise loves to sit in W sitting. And Avery's constantly, she catches her, she's like, Uncle Keith, you would yell at you for sitting like that crisscross applesauce. Because when you sit like that for a long period of time, it can cause kind of wear down on those hips and they don't function normally. And they actually can pop out as kids. So tailor sitting can cause you to get ischiogluteal bursitis. Yeah, it's a lot of parents don't. A lot of parents allow their kids to sit in W sitting, and it causes problems with hips. I would be willing to bet if you go back to my time period, it led to a lot of women getting patellofemoral pain syndrome. Kneeling one's fine. Yep. I mean, yeah. Ideally, yeah. Ideally, the best type of kneeling is for the martial arts is where you sit on the balls of your feet too. That actually is a little bit more stable for your legs. But yeah, kneeling is fine. It just, you get tight sitting there for, you know, if you have to sit there and listen to the history of Taekwondo for 20 minutes, eventually your legs are going to be burning. But ischiogluteal bursitis, problems with the ischium, right, causing the gluteal muscles to get inflamed. Makes sense. Some of you probably have had ischiogluteal bursitis before and never known it. Does anyone here ride motorcycles? I can't remember if we have any motorcycle riders or not. I don't think we do. I think I might be the only one. A lot of times if you ride on the motorcycle, you can get ischiogluteal bursitis just from the position, especially if you're riding one of I almost called them what they are. The motorcycles where you're bent over, like the Ninjas and the Kawasaki's and stuff, like the Kawasaki is a Ninja. The Suzuki SVs and stuff like that. That can cause it. You can also get what's called monkey butt too, but that's beside the point. Femoral acetabular impingement. I don't have to pretty much explain this. FAI is caused by a condition called femoral megaly. Femoral megaly literally means what? Big femur. Yeah, right? Enlargement of the femur. And patients will get this where, for whatever reason, their the head of their femur is just too big. And there's a couple of options they can do. I have that on my right hip, and I don't know if it's from probably the leg length discrepancy. And that's why I have partial tear of my labrum. They can go in and they can shave that down and make it smaller, make it fit better. But when they shave that down, they make that femur head weaker, which means it's likely to fracture. Better just to live with the impingement, right? So if I have femoral acetabular impingement, a lot of times what's going to happen is that labrum is going to kind of slide in and get pinched. Or some of that articular cartilage will get pinched. Or maybe one of the ligaments will get pinched in there. And sometimes you'll see that if somebody's got it, they'll be sitting there kind of rotating around their hip until they get that, oh, there it was for me, that nice pop. And the pop necessarily isn't the hip popping, but it's whatever's stuck kind of popping out or wherever it's stuck at. A lot of times if you have this, they're going to avoid weight bearing on that side because that side hurts, right? They'll end up with imbalance in muscle flexibility, neuromuscular control, and decreased overall muscle endurance. So again, for that, we're going to look at what the problem is. If the right hip is the problem, we're probably going to have to strengthen the right hip and stretch the left hip because this left hip has probably gotten tight. So we'll do a little bit of both because we want to balance them out. The main idea for all of these, whether we're talking about FAI or whether we're talking tendonitis or we're talking bursitis, is controlling the inflammation. If you're in an inflamed state, do we use heat or cold? Cold, preferably. Unless we're in a chronically inflamed state where we have chronic swelling, then we may do heat. Patients will gravitate towards heat because they like the feeling of heat. So you got to tell patient, all right, Mr. Patient, can't do this. We got to use some cold on that to get the inflammation down. They may be prescribed ibuprofen. So ibuprofen has two effects, right? I've talked a little bit about it before. Ibuprofen has an analgesic effect immediately, meaning it relieves a little bit of pain. That's why you can take it for a headache and it helps you. But ibuprofen's main effect is non-steroidal anti-inflammatory, right? And the D stands for drugs. In order to get to that NSAID effect, you have to take it for about 6 to 8 days. And this is where a lot of people make these mistakes. The doc will give them, like, maybe you've got bursitis, and they'll prescribe you the 800 milligram ibuprofens. You'll go home, you'll take them. The first day you feel a little bit better because you've got that analgesic effect. The next day that analgesic effect's not working as well. The next day it's not working as well, so they stop saying, medicine's not working. Well, the medicine's not working because they haven't given enough time to kick in. So sometimes as PTs and PTAs, we have to educate the patient. The doctor gave you a medication. They gave it to you for a reason. You need to take it for its course, right? Steroids are an excellent example. Why do people not want to take steroids to help with inflammation? What do steroids do to you? So maybe something like hydrocortisone or a methylprednisolone pack. Anyone ever taken any of those? Yeah, weight gain. Right? Even if you're taking them for a short period of time. Like, so the methylprednisolone packs are the packs where, like, the first day you take 10 tablets. The next day you take 10 tablets. The next day you take 6 tablets. And then you take 6 and 6 and 6. Then you take 3 and 3 and 3. Then you take 2. And then you take 1. And that's called a taper dose because you taper down off of it. But man, that first day that you take those, I don't know about you guys, but when I take those, there's not a snack in sight that survives in my house. Because it just kicks up that cortisol effect where you get hungry. So they've got to overcome that. But the goal of it is to reduce that inflammation. If we can reduce the inflammation, that means the mitochondria can work on healing the area. And then we have to develop support in the related areas. If I've got problems with my hip, probably going to have back pain. So I've got to kind of think about that when I'm working with them. I may have to do some kind of pelvic tilt stuff to kind of loosen up the back as well. Any type that we've had any type of stuff like this, we want to develop a strong mobile scar and regain flexibility. We got to get anything that's torn in there mobile and hostile again. We got to get it kind of working. Develop balance between length and strength of the muscles, right? We've got to make sure that both the hip muscles, the anterior surface, anterior compartment, lateral compartment, posterior compartment, medial compartment have adequate length and adequate strength. So there should always be a stretching program for almost every patient that you see it with a hip, right? The more cardiopulmonary endurance the patient has, the better they're going to be. And then just general patient education. If your leg hurts a ton, stay off of it for a little bit. Right? Give it time to calm down, then get back up. Don't stay off of it forever. But, if it's flamed up and irritated and mad at you, maybe get off of it for a little bit. Give it time to calm down. And then we get to that return to function phase, which we've kind of hit with almost every patient, right? Where we kind of get them back to where we are. All right, so we're going to do a little lab on this, talking about stretching different hip structures. And we'll talk about that when we get into the lab on Tuesday. We're not going to go into lab. We're going to go into lab as a group like we've been doing. But we'll talk about how to increase hip extension, hip flexion, hip abduction and external rotation, and then hip internal rotation. We'll talk about rectus femoris versus hamstring versus quad stretches, TFL stretches. Probably the TFL stretches are probably ones that when we work on these that you guys will really like. If you stretch the TFL and the IT band out a little bit, you can avoid foam rolling them. And out of everything that in my life that I despise, I hate foam rolling my IT band. Open chain exercises, develop control and strength of hip abduction. There's all kinds of exercises we can do here with open chain. Understand most doctors are going to order for you to do open chain before you move to closed chain and move to weight bearing activities. And the idea is to develop stability and strength before we start getting into mobility and function. Closed chain isometrics, closed chain dynamics we'll kind of go through, and then it's kind of functional progression for the hip. All right, we got through that faster than I expected.